welcome all today on 6th of September 2020, Sunday. Welcome all to this AMOGS and Maharashtra chapter of IAG webinar, Endoscopy for All, Endoscopy for every gynecologist. And today we are going to talk on endometriosis. And we have with me our guest of honor, Dr. Nandita Palshetkar. Dr. Nandita Palshetkar, madam, is the president of AMOGS, that is All Maharashtra Obstetrician and Gynecologist Society. We all know that last year she was the president of POXI and it was a wonderful year. In 2019, she was also the president of MOGS, president of IAG, vice president ISAR, and she is the professor in obstetrics and gynecology at DY Patil Medical College, Navi Mumbai. She has been practicing infertility for last 25 years and she is the director of 9 Bloom IVF centers. I request Dr. Nandita Palshetkar madam to share her pearls of wisdom and inspire today's webinar. Madam Nandita Palshetkar.
Thank you, Niranjan. I think you are such a charming person and you give such a wonderful introduction. I think on behalf of Maharashtra OBGY Society's AMOGS, I would like to welcome everybody and congratulate you on conducting this webinar. You know, as a IAG president, my vision always was that all gynecologists need to learn the basics of endoscopy. Everybody needs to know endoscopy because it's a very, very important tool. And you've got such fantastic endoscopists today. I think Dr. Alka Shailesh Puntambekar, who are your main speakers. I think that's amazing, fabulous knowledge which will be there. And my colleague, Dr. Rishikesh Pai, as your guest of honor, he is the president-elect of FOXI, and I'm sure he'll have a fantastic program. And really the panel, I think endometriosis, there's a lot of change in treatment, and I'm glad that you've got a lot of young people, Abhishek, Nitin, Ashish, Amay, Sanket, and I think 2 IVF specialists, Rohan and Ashish. I think that's required because there's usually a debate between the endoscopist guys and the reproductive endocrinologists. And I think it's wonderful to have them together. And Prakash, as the president of the MAGE, I think it's a wonderful job which you're doing. And I wish you the webinar a complete success and your series a complete success. Thank you for inviting me there and looking forward to hear Dr. Alka Kriplani and Dr. Puntambekar, who are age-old friends. You know, it's always a pleasure to see them. We can't meet in person, but on the screen, it's really great seeing them, and all the best. Thank you.
Thank you, madam, for those inspiring words and the pearls of wisdom. I remember your work in IAG and FOXI, and obviously the vision which you have. That's the need of the hour. We are all senior gynae consultants and the junior consultants which are there spread across the breadth of India. This is what is demanded, endoscopy for all, and that's the topic demand, and then they command the topic. And that's what endoscopy should be known by every gynecologist. Now I call upon, thank you madam, now I call upon our next guest of honor, none other than the charming man. Like an elusive endometriosis, he is not at all elusive. He is totally approachable, totally available for every single gynecologist, not only in India, but a charming man across the boundaries. I don't want to put a lot of adjectives. Let's come to the point. We know he's a director of Bloom IVF Center. He has been working for IVF more than 32 to 35 years and has got numerous awards and presentations to his credit. But presently, he is representing India on the world map, and he is the director of corporate affairs of the International Federation of Fertility Societies. We all know the work which he has dedicated himself to FOXI as the Secretary General, as Vice President and as Chairman. and also he has donned many hats where he was the president of Mumbai Obstetric Gynec Society in 2009, IAG and SR. Sir, I welcome you to share your pearls of wisdom with this series of endoscopy for all, endoscopy for every gynecologist, and kindly encourage this webinar with the beginning with your pearls of wisdom. Thank you, sir.
Thank you, Niranjan, for inviting me. I'm really privileged to be here amongst so many stalwarts. And as Nandita said, that for us, IIG is an important organization, and we are very passionate about it. I remember when I was secretary, the organization had literally been, in having problems, and I had to really, as a secretary, there were cupboards that were spread all over Bombay. I had to the one cupboard was lying somewhere, another cupboard was lying in some garage. I had to bring all those cupboards together when I was secretary of IIG. Then there was, the Bhandarkar, our secretary had just expired, and there was no. I brought all the member list together. I remember my president at that time was Dr. Sham Desai, and you have also been like that. You have been a very active person in the this endoscopy area. I know that you have been conducting a lot of live hands-on training, so workshop in your wonderful simulation laboratory that you have in Sion Hospital with all the equipment from Sweden and Germany. So many people have benefited from that, and then you have given so many lectures. Especially your work in the last 5 months on in the COVID patients, where you have treated more than 130 patients in Sion Hospital, which are COVID positive, and overall 350 patients have been treated by Sion Hospital. It's a fantastic work that you all have been doing. And the one of the things which really makes you stand apart is the so many seminars that you have conducted, nearly more than 50 seminars, all people from all over the world, like United States, Spain, Germany, UK. So many people have been brought in, and it's been a great experience which I've had with you. And the work that you have done in the MUHS, and since 2011, and nearly 11 batches of training have been conducted, and so I can go on and so forth. But it's been a fantastic, and what I feel is that all our 38,000 members, we should know how to do basic endoscopy. For example, everyone should be able to remove a 5 centimeter fibroid, a 4-5 centimeter. Everyone should be able to tackle a 4 to 5 centimeter endometrioma. Everyone should be able to tackle a simple hysterectomy. This is what is important, not going for hi-fi. In fact, you should know when to not use. There should be a Lakshman Resha where beyond which you should not go, because the complications go unless you are a great surgeon, and none of us are great surgeons. We are average surgeons. But medicine is made up of average people, not great people. Average people giving a standard care. That is what good medicine is all about. Not a few people giving great care. That is not good medicine. So the objective of the future, all of you are in IG, is to see that each and every endoscopic surgeon is able to tackle 80 to 85% of work on their own, not calling someone else from outside to tackle that work. And that is what you should do in the next 10 years. You should consolidate this organization and see to it that every person can do their own endoscopic work without calling others. For unless it is a complicated work, you refer it to others. So this structure should be kept in place. I don't want to take your time. We wish you the very best for everything that you do, and I'm sure that you will also, as you have achieved so many accolades, you will achieve the accolade of treasurer of IG in the future as well. Thank you.
Thank you, sir. It was a very encouraging piece of advice which you have given, and it has come from a man with a heart. We have a heart and a brain, but he is a man with heart, and he knows what he talks. And leading such an organization, I appreciate your gems and those pearls which you have given. Thank you for giving us that valuable time, both of you. I request you to please be here for some time, and then we will proceed with our proceedings. Now I call upon my chairperson of Maharashtra chapter IAG, Dr. Prakash Patil. Sir is a consultant in IVF and an endoscopic consultant. He has a very big hospital, Lifeline Hospital in Panvel. And we all know he is a member of IAG, member of ISAR, member of AMC, and he is also the charter chairman of our MAGE. He has got many awards, especially from the government of Maharashtra for the best work which he did in family planning. Kanushri Patanjali Puraskar, best of the best IVF centers. Sir, you are a doyen amongst doyen, and we are very proud that you are leading such a wonderful organization of Maharashtra chapter. Thank you so much for being there. Now I request you to please start the program with a wonderful, beautiful presentation of yours. Thank you.
Thank you, Niranjan, for those kind words, and congratulate you for having this webinar and bringing together all the pearls, all the legendary personalities amongst everybody. I think we are supposed to thank to Nandita as well as Rishikesh and all the legends, Alka Madam, for joining us to have this program of AMOGS and MAGE. I think we should start with the introduction of Dr. Shailesh Puntambekar. Am I correct?
Yes, sir. Yes, sir.
Yes. So, dear friends, it is really a proud privilege for me to introduce such a legendary person, legendary laparoscopic surgeon and a robotic surgeon. I will say that rather than reading his biodata, which is a very big list of that, the most important thing what I want to highlight, that we are proud as Indians that just now Rishikesh said that all are average surgeons, but extraordinary surgeons are very few, and he is one of them. कधीतरी जन्माला एक असा माणूस येतो की जो असं काहीतरी करतो. So I just wanted to highlight that he is a person, he is a surgeon, but he has achieved too much in gynecologist. He has patented the technique of radical hysterectomy, Pune technique of laparoscopic radical hysterectomy. He has conducted India's first successful laparoscopic assisted uterine transplant. A baby girl was delivered on 18th of October 2018 at Galaxy Care Multispeciality Hospital. He is the only Indian to be the board member of AAGL. He is operating faculty at IRCAD and various other international organizations and their conferences. Largest series of transthoracic esophagectomy, endoscopic and robotic he has done. He is known for performing the most difficult laparoscopic endoscopic surgeries like thyroid, renal, upper GI, colorectal. He is a pioneer of laparoscopic anterior and posterior extra-pyramidal of colorectal and uterine malignancies. I would like to highlight here particularly when he does the lateral pelvic dissection during the radical hysterectomy is fantastic. Everybody is just watching to, he just carves each and every thing in the pelvis and shows it very nicely. So everybody really appreciates that. I just want to say one small thing regarding him. Once a senior urologist from South Africa, he had a prostatic cancer and he was told to get operated. The first name he said that if I want to get operated, I will be getting operated by Shailesh Puntambekar. That is the achievement of Shailesh Puntambekar. I'm really proud, Dr. Shailesh. You are a legendary person in laparoscopic surgery. I will invite you to talk on today's your topic. Please come forward. The dais is yours.
Good evening, everybody. Thank you very much for such a kind words, Dr. Prakash Patil. It's a pleasure to have Nandita, Rishikesh chairing the session, and all the best, Niranjan. I'm sure you're going to win this election. So I hope and I pray that you win this. And it's a pleasure to be in the evening to discuss these topic. And this is a topic which is very, very dear to my heart. And that is something because, as Rishikesh said, endoscopy should be done by everybody. And if you want to do any kind of endoscopy, the basic pillar of any kind of surgery, I feel, is the navigation into the pelvic anatomy. And this is the most important thing. You should not be only concentrating on anatomy as an anatomist, but why this anatomy exists and how you can use the knowledge of anatomy to do good surgery. So surgery is an art of fascias. You find the network of fascias and the planes will lead to bloodless surgery. And the term that I always use when we do laparoscopic surgery is called as the predictive anatomy. That is, you need to predict the structure before it comes, more so when you are doing endoscopic surgery. What lies where? What comes next? Anticipation is not to be on the impulsiveness, but anticipation should be based on knowledge. And that is what we call it as predictive anatomy. We all know how the organs lie in the center, and we have this bladder, uterus, and rectum. And we are going to discuss the four important aspects of anatomy: the sacral promontory, the spaces, the fascias, vessels, and the nerves of the pelvis. The sacral promontory is the highest peak. In no pathology on the pelvis reaches up to the sacral promontory. Now, if that is the knowledge that you have, whether it is endometriosis, large cervical fibroid, large fibroids, they will never reach up to the sacral promontory, then you should begin your dissection at the level of sacral promontory. Why to begin at the level of sacral promontory? Because three things happen at the sacral promontory. The most important thing is the bifurcation of the common iliac artery into the external and the internal iliac artery, and the ureter crosses from the lateral to the medial side, thereby remaining as the most medial structure in the pelvis. So if you remain medial to the ureter, there is a very less chance that you will damage any vascular structure. The third thing that happens here at the sacral promontory is the superior hypogastric plexus. So if you take a stitch while a sacrospinous fixation too medially, you are likely to damage the superior hypogastric plexus. What about the spaces? We have these four spaces which are important. Let's not go into the details of running like an anatomy. This is the anatomy of the pararectal space. Pararectal is lateral to the rectum. If at all anybody asks me which is the space I should master, I always say it is the lateral pararectal space. You take a peritoneal cut medial to the infundibulopelvic ligament, identify the ureter, remain parallel and lateral to the ureter. Just remain parallel and lateral to the ureter. The first structure that you see is internal iliac. If you go parallel and medial to the ureter, the first structure that you see is called as the hypogastric nerve. So you have two spaces, the lateral space called as the Latchgo space. The only structure that crosses it transversely is the uterine artery, and in the depth lies the S234 nerves, which you can very clearly see, while on the medial side it is called as the Okabayashi space. So this is the pararectal space. You can see it is crossed by uterine artery, the only structure that crosses this artery transversely. This is the uterine artery. So if you master this space, taking the uterine artery is a child's play. This is the pararectal space. This is called as a Latchgo space. L for L, lateral to the ureter, Latchgo space, only crossed by the uterine artery, medial to the ureter, Okabayashi space, and the only space which is the nerve is the hypogastric nerve. But the most important thing you have to watch here is the uterosacral. Both the spaces lie lateral to the uterosacral and lie at the base of the uterosacral. If you understand this anatomy, when you want to do a total laparoscopic hysterectomy, if you remain at the apex of the uterosacral, there is no chance of you damaging the uterine artery, the ureter, or the nerve. Simple knowledge of anatomy helping you to do good surgery. This is again to show you the pararectal space and the paravesical space, and the only structure that crosses it is the uterine artery. So this is very, very important. There are two ways to approach it. One, you can go from the medial side of the infundibulopelvic ligament and like you go on the sacral promontory, or you can go from the lateral side, which is called as the oncological approach. Now this is how you can go from the lateral side. You can see you cut the anterior leaf of the broad ligament, cut the round ligament, And once you cut the round ligament and the anterior ligament, then you can see that this is the ureter which comes into play. You can clamp the infundibulopelvic if you want to take it, and then go and try and identify the ureter. Look at the uterosacral, it is always at the base. Once you identify this, then you will see the ureter coming up. That's the ureter which is coming up. Now you remain parallel, and this is parallel and lateral. Look at that, just a parallel and a lateral stroke, and the only structure which will be seen crossing the pararectal space is going to be the uterine artery. So it is a very, very easy way. Now you push everything towards the uterine artery, that opens the paravesical space. So these are the way in which you should do. This is the dissection of the paravesical space. Once you identify the uterine vessel, remain parallel to the uterine vessel and not parallel to the ureter, and push. So it's all P, parallel, push, always. And this you keep on pushing till you reach the paravesical space. Look at the way, this is the uterine artery. Remain parallel to the uterine artery and push everything towards the uterus. This opens the paravesical space. The only structure that crosses transversely the pararectal and the paravesical space is the artery and the vein. This is one space which is I have made this dissection being doing from a lot of people who have worked with me, and I find that every gynecologist who has worked with me or who has come for training is able to do this dissection, indicating that it is a duplicable dissection. So this is again few pictures to show the pararectal and the paravesical spaces. What about the prevesical space? The prevesical space lies between the two you can see obliterated hypogastric arteries, also called as the median umbilical ligament. So never go lateral to the median umbilical ligament. If you go between the two median umbilical ligament or the obliterated hypogastric arteries, and with a very, very clear rule, fat belongs to the bladder. So when you want to dissect the bladder from the pubic symphysis, remain above the fat, and you can see that you can enter this space very, very easily. Certain rules, that follow the rules, believe the anatomy, and you will see that you can certainly do very good surgeries. Just remain above the fat, never go below the fat. This is how you open the prevesical space. What about the arteries? We all know the arteries. We are not going to talk about them, but what I would like to show you is this area. This is the bifurcation of the common iliac. At the level of the bifurcation, especially in postpartum hemorrhage, people tend to ligate this artery very close to the bifurcation. You have a common iliac vein immediately below this. Don't try to ligate it at the level of the bifurcation, because there is anterior division and the posterior division, and the common iliac vein is in close association. And therefore, if you go a little more distally, you will find that the anterior division travels for a distance of 5 to 6 centimeters before the first branch, which is the uterine artery, which is given. You can see the second branch, which is the superior vesicle. So the anatomical knowledge that there is enough length of the anterior division available for ligation should help you to do the ligation at a more distance. Again, to show you, this is the anterior division. The posterior division dips down, and you can see a long length of the internal iliac available for ligation. So just push a little bit, go more distally, and you will be able to find this. What about the other space? I will discuss this space. This is the Yabuki space. Now this space has become very prominent, especially for people like Madam Altra Kruplani and Sanjay Patel, all those who are doing endometriotic surgery, because that's the space where the nerve enters into the bladder. It is called as the fourth space of Yabuki and is medial to the ureter, characterized by the presence of inferior vesical vein. What about the structure of the vein and the artery? If you see Gray's anatomy, they say that they accompany. It is not. The vein goes below the ureter. The artery goes above the ureter. One may ask, why do you want to know this? Very simple. If you are doing and there is bleeding, just understand whether it is arterial bleeding or venous bleeding. If it is a venous bleeding, it has to come from below the ureter. Just lift up the ureter, you will find the venous bleeding. If it is an arterial bleeding, it will come anterior to the ureter. Knowledge of anatomy helping you to do good surgery. The only branch of the external iliac artery and the vein in the pelvis is the inferior epigastric artery. Thus, understanding that there are no arteries, no tributaries, and no vessels of the external iliac. Using this knowledge, the way in which the pelvic node dissection should be done always remain parallel to the large vessels, and you can easily do the pelvic node dissection. The only branch of the internal iliac artery which is arising from the medial side is the obturator artery, and you can see the obturator artery going below the obturator nerve. So if you know that it is the artery and the vein lying below the nerve, the principle is do your nodal dissection always remain anterior to the obturator nerve, because if you go below that, you are going to land up into bleeding. Again, the knowledge of anatomy helping you to do good surgery. And then if you see this is the obturator vein below the nerve, and it joins the circumflex iliac vein right on the pubic bone, forming the corona mortis. So this is a branch of the external iliac, and this is a tributary of the internal iliac. It is more important for the general surgeons who do hernia surgery and put a tacker there when you put the mesh. So this is again the two umbilical ligament, which is the obliterated hypogastric arteries, which you can see very clearly, indicating that this is the prevesical space. This again, I am showing you the prevesical space. Then we talk about the cervicovesical fascia. What are the fascias? How do you dissect the bladder? If you want to dissect the bladder, especially in difficult case, go from one round ligament to the other. This is, I call it as the anterior U-cut. And then go with the principle of fat belongs to the bladder, so remain below the fat, just remain below the fat, and you can see how easily you can go and dissect this, because there underneath that lies the cervicovesical fascia. So all these knowledge of anatomy is very, very important. Fat belonging to the bladder remain below the fat and remain anterior to the uterine vessels. Then you can see below that is the cervicovesical fascia. So all these pictures to show you how the fat belongs to the bladder, and the idea is cut and push and remain below the fat. What about the rectovaginal space? This is of the most important space if you are planning to do a endometriotic surgery. This is the space which is always adherent, and you should always go with an idea that fat belongs to the rectum. This word and this sentence has become famous all around the world. Everybody knew how to do it, but I just gave the meaning and the word to the anatomy that remain above the fat, and you will go between the two layers of denonvillous fascia. This is how you can see there is one layer of denonvillous fascia goes with the rectum, one goes above with the vagina. So these are the two layers of denonvillous fascia. This is how you should understand and do the knowledge of anatomy to do this. And again, I will show you, this is why this I am showing you is because very important. Pull up the rectum, go above the fat. You can see the fat there. Never go in between the fat and believe that this is the anatomy. All the veins lie below the fascia. So if you remain above the fascia, there is no damage to the veins. In good old days, when you put the fingers while doing a hysterectomy in this space, it bled because you transgressed the fascias. So one layer is going with the posterior vaginal wall and one is going, this is the denonvillous fascia. And most important thing, a lot of people will ask, why do you don't get adhesions when you do laparoscopic surgery? Because laparoscopic surgery is intrafacial surgery. And according to Gray's anatomy, any kind of anatomy, the fascias lack fibroblast. So when you go intrafacially, there is no fibrosis. That is the reason you do not get fibrosis, and that is one of the biggest reasons that you should be telling your open surgeons that laparoscopic surgery is without adhesions, because we don't transgress the fascias. And this is finally the dissection I'm going to show you of the Yabuki space. This is the space which opens. This is for the, because your topic is endometriosis, this is one space which is understood a little less. If you want to dissect the ureter, remain anterior to the ureter or on the lateral side of the ureter, because the mesentery of the ureter lies always on the medial side. You can see the nerve as it enters the bladder, and this is the space which is medial. If you want to do nerve sparing, you have to go in this space and identify this space. And once you identify this space, this is further characterized. You can see this is the space, and this is further characterized by the presence of the anterior cervico-vesical ligament and the posterior cervico-vesical ligament. You can see the cervical fascia, how it splits into two to accommodate the ureter. If this was not splitting into two, you would not be required. It is just the presence of ureter which makes this anatomy difficult one. So once you cut the cervico-vesical fascia, also called as the ureteric tunnel, the ureter will go away and you can do this area. So I'm not going to show you. So the key point is about now coming to the ureter. This is very, very important because ureter is our friend. We should never worry about the ureter. Always identify the ureter. If it is difficult to identify lower down, come to the level of the sacral promontory. You will always be able to see the ureter at the level of the sacral. I would like to show you how you should dissect the ureter in endometriosis. Always remain on the anterior or the lateral wall of the ureter, because the mesentery of the ureter lies on the medial side. There is a branch of the uterine artery which supplies the ureter, and look at the way in which the ureter should be dissected. Never hold the ureter. I hate the people who hold the ureter. This is not a good way of doing the surgery. Handle it with care. You can see how the ureter gets lateralized, and this is the way in which you should be able to do this. The ureter is the most important structure. I just want to show you how it gets into this area. I'm going to take you a little forward just to show you that the distance between the uterosacral and the ureter is 4 centimeters. And this we have measured and published. Contrary to the fact in TLAN it says at no point of time ureter is less than 1.5 centimeters. The book is wrong. It is 4 centimeters at the level of the uterosacral, and as you proceed, you will find that it is more and more. So this is very important to understand that ureter is at the base of the uterosacral, always lateral to the uterosacral. It is always having the mesentery on the medial side of the uterosacral, and you will see that there is only one branch of the uterine artery which is supplying the ureter. Once you take the branch, it is like water under the bridge. If you understand this anatomy of the ureter lying between the vein which comes from below and the artery above. So this is lastly the endopelvic fascia, which is important, but we will finally go to the nerves. I'm just going to show you the nerves. This is the last part of my, so if you see, this is the medial part. The hypogastric nerve lies medial and parallel. It lies medial and parallel to this is the nerve. It lies medial and parallel to the ureter. At the level of the uterine vein, it is joined by the S234 fibers. So it is at the level of the uterine vein, always at the level of the uterine vein. So if you want to do nerve sparing, you should take uterine vein medial to the ureter. The nerves S234 get completely separated out, and this is the hypogastric nerve and the inferior hypogastric plexus. So if you see the hypogastric nerve in a correct manner, you will see that this is the nerve on the left side. This nerve is parallel and lateral, medial to the ureter, and then it is joined by the S234 nerves to form the inferior hypogastric plexus, from where the pelvic splanchnic nerves go and supply the bladder and the rectum. So this is at the level of the uterine vein. This is how the anatomy is seen from underneath the peritoneum, and you can see the pelvic splanchnic nerve, and this is the anatomy after you explore the peritoneum. So you see, you can do a very good job remaining there. Understand the ureter is the most medial structure, and for the gynecologist, the Lakshman Rekha is the anterior branch of the internal iliac, like the obliterated, because if you go lateral to it, you get the obturator nerve and the external iliac anatomy. Just to show you that this was a patient of VVF that we had, Now, if you follow this anatomical rules, how you can use this anatomy, this was a completely stuck area, and
No
then we
question.
went medial to the to the median umbilical ligament or the obliterated hypogastric artery, because we know that the bladder lies there, and went anterior to the fat. Similarly, the rectovaginal space dissection, this was a patient with a uretrovaginal fistula referred to us. The rectum was very badly stuck to the vagina. You push the vagina and then believe that the fat belongs to the rectum. So you see, without using any energy source, you can do this. This is the rectum which was badly stuck. Believe the anatomy, the rectum is stuck. Don't go there. You will understand that you will land up into problem. Come from the lateral side. Go and open the space by understanding what is the important area. So this is how you use the knowledge of anatomy, not using any kind of energy source, just remaining above the fat, and I could separate the rectum very easily. The same is the story in any kind of endometriosis. You can use any kind of manipulators, but the important thing is to understand the anatomy. The anatomy remains the same, and this is very important. And then lastly, I would like to show you one last applied anatomy. When you have a very large ureter like uterus like this, the person wanted to do a big myomectomy, then you would like to clamp the uterine artery. Again, follow the way of dissection. So if your hands and eyes are trained parallel and lateral to the ureter, go there and you will find the uterine artery there. So you can see this is the uterine artery. We went parallel and lateral to the ureter, and once we saw the uterine artery, we can clamp the uterine artery temporarily if you want. So in difficult cases, this knowledge of anatomy is of great use, and therefore these are the final 10 commandments that you have all seen, that the fat belongs to the rectum, fat belongs to the bladder, the dissection should be parallel to the tubular structures, the ureteric tunnel is a condensation of endopelvic fascia. But the 10th most important thing that I would like to bring to your notice, more than 1,000 radical hysterectomies I have done, I have yet to find an uterine artery arising from the external iliac. The anatomical variations in the vascular structure and the nerve are almost not there in female. So no excuse to say that I don't want to learn the anatomy. Irrespective of what kind of surgery you do, anatomy, and nothing else but anatomy remains the basis of your surgery. Thank you again, Niranjan. Pleasure to be with you and sharing the dais with Madam Alka Kliprani. Always a pleasure. I miss going to Delhi. I hope I can meet her again in person someday soon. Thank you so much.
Thank you, Niranjan. Yes. Thank you, Dr. Shailesh Puntambekar. As usual, your hands are magical, your dissection is magical, and thousands of gynecologists, they take lessons from you and they're trained under you. So once again, thanks for coming and sharing your skill and your knowledge with us. Thank you very much. I will request Dr. Niranjan to go ahead with his comments.
Sir, you are a teacher of teachers. And what more can we ask to God? But none other than God of surgery and laparoscopic radical hysterectomy.
That is like flattering me.
Coming down and teaching us the first basic course of 3 magical words which you have given the mantra. Sir, I am not just praising you, but people from Malaysia, from Nepal, from Egypt, from Munich and India have joined today just to hear you. I just broadcasted that I am live with Dr. Puntambekar sir, and you know what, in the midst of your lecture, people have started telling me that we want the recording. I said, first you listen to sir, I will surely send a recording. That's the amazing charisma which you have given, and the 3 words are not entertainment, but anatomy. So
Yes.
I think, sir, there are no questions because you have simplified in such a wonderful way. And endoscopy for all, endoscopy for every gynecologist. is guided by none other than Puntambekar sir. Thank you for your valuable time, and we will catch up with you soon. God bless you. Please be there. We will again be calling you for the further ahead of laparoscopic radical hysterectomy and your beautiful way of doing surgeries. Thank you, sir.
Thank you, Niranjan. Thank you.
Now I request Dr. Prakash Patil sir to please introduce Madam Alka Kriplani. Madam Kriplani has been busy every alternate day. She's been all the time been called, and she is an authority of AIMS and of endometriosis. Madam called me today afternoon. Niranjan, please can you excuse me? मैं बोला no madam, I can't excuse you because you're a professor, you're a teacher, and I thank you to be there. I request Dr. Prakash Patil to please start madam session. Thank you, sir.
Prakash sir, we can't hear you.
Prakash sir, please unmute your mic.
Yeah.
You were going. Yeah, please, sir. Carry on.
Well, am I audible?
Yes,
Yes,
sir.
sir.
Yes, sir. Yes.
It's a proud privilege to introduce Dr. Alka Kriplani. Madam, you are again one of the legendaries in laparoscopic surgery. In Delhi, you are the person who everybody want to follow you. Dr. Kriplani was a director. She is the director and head of the Department of Gynecology, Obstetrics and ART at Paras Hospital at present. She is the ex-professor and head of the Department of Obstetrics and Gynec. She was a president of FOXY during 2016. She was a president of Gynecological Endocrine Society of India 2011. She was a president of Delhi Gynecological Endoscopic Society during 2014 to 16. She was a president of AOGD during 13 and 14. She was editor Asian Journal of Obstetrics and Gynecological Practices during 1999 to 2017. Vice President FOXY 2009 and National Corresponding Editor Journal of Obstetrics and Gynecology of India. The list is big and big and big. She is a really, we have seen her surgeries live, and she's a fantastic laparoscopic surgeon and one of the well-known gynecological surgeon. Thank you, madam, for sharing your time, giving us your time for Maharashtra chapter of IAG as well as for AMOGs. Thank you very much, and please proceed for your lecture.
Thank you very much for your kind words, Dr. Prakash Patil. First of all, it's not an easy task to speak after Dr. Shailesh. And every time I listen to you, Shailesh, there is something to learn from you. So I'm lucky that I'm listening to you carefully and imbibing. I'm very thankful to Dr. Patil and Moggs and above all Niranjan. Niranjan, you are really growing so fast, so well. You are growing in, knowledge and wisdom and maturity, but I can see that you are losing so much of weight. So I don't know what is the secret sitting at home. How can you lose so much weight? And last time when you organized and I was there second day, all my staff was asking, madam, the way it was being coordinated by someone called Dr. Niranjan, it looked like it was a very big program. He was so good in organizing. And Niranjan, you are really very good.
Thank you, madam. Thank you.
The way you talk, it reminds me of Arnab Goswami.
You're right, madam.
So, to be fair to your panel, I would like to be, I would like to save some time. So, I bring you greetings from Paras Hospitals, Gurgaon. we are really in a very bad phase because COVID is okay, but not meeting friends. As Dr. Shailesh said, Dr. Pai said, मैं तो नहीं आएगा दिल्ली जब तक वैक्सीन नहीं आएगी. It's very difficult, to be without friends anyway. So topica sound is deep endometriosis. So what is deep endometriosis? So everything which is below the peritoneum, the rectum, the bladder, the ureter, everything is deep endometriosis. And very wise people said that endometriosis surgery, because what we are witnessing in this COVID time, my surgical work is really on endometriosis because they are having back pain, they are coming out, otherwise patients are scared to coming to especially multi-speciality hospitals. So I am daily operating endometriosis and deep endometriosis. So when to operate, again, not every endometriosis requires surgery and there are specific indications. Even in deep endometriosis, if they are asymptomatic, one really has to. And once you are going for surgery in deep endometriosis, you should enter full-hearted, because once you dissect in that area and you leave the patient, from the person coming next to operate, like we get patients after 3-4 surgeries, it really becomes difficult because of fibrosis. So either they should leave it there, or if you are dissecting, you should do the complete job. Now, more and more patients are getting married late and producing children late. So the question of doing conservative surgery in advanced and deep endometriosis is becoming a reality. And that is the reason we all need to have very in-depth knowledge of anatomy and doing conservative surgeries in these patients. When it comes to ablation versus excision, whether it is ovarian endometrioma or deep, excision is always preferred. Why to do open or laparoscopic or robotic? So laparoscopy, as Shailesh also said, it's actually you put the scope and the endometriosis whole disease in very surgeon friendly view. The pouch of Douglas is in front of your eyes. You do open and it is very difficult to visualize the area. And when it comes to robotic, colleagues will agree that robotic has not much role, except that it is for surgeon's comfort and you can sit and operate. So why surgery is challenge in advanced endometriosis? Because extensive dissection is required, extensive knowledge of anatomy is required, and being a gynecologist, you handle with ureter, bladder and rectum, and majority of colleagues are not comfortable and everybody has their limit to stop. And once you decide to operate, pre-op assessment, counseling, these are very important. Taking history, especially history of surgery, is very important, because usually we get patients who are operated 3, 4, 5 times. So what all has been done, what dissection has been done, it really helps. Examination is very important. Many times you see you do perspeculum examination and you find nodule in the vagina. Imaging is very important, and there are two things: transvaginal, if you are very good with that, or MRI, especially for deep endometriosis, and knowing extent of involvement of the wall of the rectum. So these investigations availability is very important. Pre-op, as I said, consent is very important. You have to take proper consents. You have to tell the worst scenario to the patient that she may require. I know the moment you mention about colostomy, highly likely that the patient runs away. But one has to give an informed consent. One has to has nice bowel bladder preparation. If it is ureter involvement, stenting. So it is a multidisciplinary approach. You have to have good colleagues with you, and starting with patient positioning. Sometimes these surgeries go very long, so you have to have proper tables, proper knowledge of anticoagulation and principles of identity. Many times you will see that it's the tip of the iceberg, and you start dissecting and you see deep endometriosis so much deeper, involving parametrium, involving uterosacrals. So one has to be prepared. Now, when we talk of principles of treating, Easy steps first. Knowledge of anatomy. I think I'll describe this on video because I don't want to take very long. So there are definite steps in surgery. Anatomy, Dr. Shailesh has taken very, very nicely. But I would like to say from gynae point of view, to make the anatomy simpler, in deep endometriosis, I have found these manipulators very, very useful. Manipulator in the vagina. You put a sponge in between the rectum and vagina. You put a manipulator or a sponge in the rectum, and these define the organ, especially when there are such bad adhesions. It makes your dissection so much safer. So, and then start from the virgin area, start where there are no adhesions. Do nice ovariolysis, following which first dissect the ureter, then dissect the bowel. So it is like mathematics for me, dissecting, and the knowledge of these spaces, it's very, very important. And then come to the affected area. So yes, many times you find cardinal ligaments badly involved, like cancer, and you have to excise the lesion. So you have to know that endometriosis, deep endometriosis, may involve literally everything in the pelvis. This is very important. When you go, the patient comes with dyschezia, painful defecation, you put the scope and you see that the rectum is badly adherent to posterior surface of uterus. Now comes your understanding of the disease, whether rectovaginal nodule is just superficial, or it is invading the muscularies of the rectum, or it is through and through. And on that basis, you have to do proper surgery. What I mean by that, if it is superficial, more and more of us believe in shaving. If it is still deeper, discoid excision. So discoid excision, either you open the mucosa, rectal mucosa or not, good bowel preparation, you can suture in the same sitting, following the principles that it should be parallel to the axis of the bowel. And this is what endometriosis, usually you find both the ovaries kissing in the midline. Do nice ovariolysis and you will see nicely preserved. If she is infertile, respect the tubes because majority of times they are open and you can achieve pregnancy. Go from the pararectal, as Dr. Shirish said, gave that in previous scar, go lateral to the bladder, go lateral to rectum, in between uterosacral and rectum, and then come up and see the area is virgin. So if you are able to open the spaces anatomically, this is where medial to uterosacral, lateral to rectum, pararectal, go deep below the nodule and then come up. It will be easier and safer for you. And this is the and these are the nerves, as Shailesh very nicely described. Nerve sparing. Now our knowledge is nowadays that you should do nerve sparing, so she has least bowel and bladder symptoms. These are the nerves, and you can always preserve, provided you start looking for nerves and preserving. So these are the principles of deep endometriosis surgery. Of course, this pitocin injection and operating in the correct plane in the ovary so that you don't damage the normal ovarian tissue, but at the same time remove all the cyst lining so that the chances of recurrence are less. So these are the principles of surgery. You don't require to do thousands of cases to say that you are expert. Knowing the anatomy, sticking to your areas and knowing your limits, gradually expand and doing safe surgery. This is very, very important. Safe surgery in these cases is very important, and many of them they conceive without IVF and are symptom free provided we are able to operate in the correct planes. When we talk of rectovaginal nodule, again, if they are mostly they are superficial, so removing, first dissect it from the vagina and then remove it. The scissors is the best instrument. You don't fear, you have no fear of putting any energy source. Harmonic can also be used, and traction and counter traction, and removing the nodule. So this is what removing the nodule and shaving, in majority of situation it helps. If it is deep, then you have to take prior consents, do nice MRI, and then discoid excision and check the rectum at the end. It's very simple. Just push a line from below, and this is what checking the rectum. And at the end of the procedure, go stepwise. See, open this pararectal space and stepwise just dissect the rectum from the uterosacrals to relieve her symptoms of dysphagia. So take baby steps, small steps. These are the mantras of safety of your surgery, and a marker in the rectum is very important to delineate the margins of the rectum. Go for completeness, try to do nerve sparing, and once you learn the anatomy of nerves, and gradually you learn that, and this is what, be stick to correct planes and don't dissect and leave. Do a full hearted job. And somebody is showing me rectum from below, and then you see wherever, if the rectal nodule is away from the anus, further it is away from the anus, easier it is. If it is very much below, so take the consent for the rectal repair as well as for colostomy, because very low down it becomes difficult. Everybody keeps showing ureteric implantation, and this is the case which recently we did. Patient had hysterectomy, had the MTP, and this is the 7 centimeter nodule on cystoscopy in the bladder. So the nodule was involving, in a minute you will see, this is the left, right ureter, trigone, and somebody did MTP, I think they perforated through the bladder, and patient started developing, and this endometriosis became, this was the picture, huge adhesions. So go from the virgin area. I'm opening the paravesical spaces. If bladder is badly adherent, go lateral, open the paravesical. You can delineate nicely and see bad adhesions, but you can always find virgin planes if you are able to go in the correct planes. So separate all adhesions, a manipulator in the vagina and cutting over it. So first finish the hysterectomy, and this is what, big nodule in the bladder, and I am opening paravesical spaces. This is the round, everything goes and gets puckered in the area. So gradually you separate out the way they are puckered, go from the virgin area, go to the disease. Somebody is showing me, it is a teamwork. Somebody is showing me very nicely from below the manipulator, and I am doing hysterectomy. So it was a case where there was a communication, but I handed it over to urologist after my hysterectomy without opening the bladder. See, huge nodule. And if it is at the fundus above, it is better off fill the bladder partially and resect through and through laparoscopically. Our urologist said, madam, it's a huge, the capacity of bladder will be, reduced, and it is involving the trigone and the ureter. Let me do TURBT, and they resected like we used to do TCRE. There is a stent in the ureter. So you see, it makes it more, difficult or more at risk, because the ureter's pliability goes away. And this is what, huge bladder endometriosis. Once you start doing these cases, and these COVID times, many of these cases, because of pain, they want to get operated, they are coming forward. And this is what we have done. A couple of cases, especially when it is in the trigone area, it is in the near the ureter, and this also is a good option for giving symptomatic relief. So resection of the nodule, and then leaving the DJ stent for 3 weeks, because he had to resect near the ureter, as the left ureter was involved with the endometriosis. So leaving these catheters for, and this leads to recovery, and patient is symptom free and pain free. So there are so many ways. It depends on how much is the extent, how much is the depth, how much is your understanding. Deep endometriosis really requires great understanding. This is again a common area for my work. Lot of colleagues send abdominal wall endometriosis, especially after hysterectomy and cesarean, that viable endometrium, and when you are removing the specimen without bag. So number of cases come with abdominal wall endometriosis. MRI really helps, whether it is above rectus, below rectus, how much is the extent. If you are doing concomitant laparoscopy, usually adhesions point you towards, but if it is superficial, we don't do laparoscopy and just resect. And drugs, they do not help because there is fibrosis around, and the drugs are not able to reach the abdominal wall endometriosis. We have very large series, and you have to excise these kind of endometriosis with the healthy margin around. Diaphragm endometriosis, I haven't, but I have heard that it leads to frozen pelvis day in and day out you handle. And the iatrogenic adhesions, they are worst. Role of hysterectomy, it is a complete cure, but in younger patients, those who want to preserve uterus. And LNG IUD, hormonal suppression, yes, it has a role. LNG IUD, especially in early cases of rectovaginal endometriosis, they may not require surgery many a times. So to conclude, adequate assessment of the deep endometriosis and perfect counseling. You spend lot of time in counseling because that surgery is very extensive and you really don't know how extensive it will become. Communication with multidisciplinary team is very important. Pre-op assessment is very important. MRI plays a very important role, especially to know the depth of rectovaginal endometriosis. Appropriate surgery, so energy sources knowing is an important. And adiolysis and systematic approach, like go from the virgin area, know anatomy, limit extent of bowel urinary endometriosis, and competent laparoscopic suturing skills are very, very important to give good results and not to open your patient. And thank you very much for patient listening. Thank you, Niranjan, for the invitation. Thank you, Dr. Prakash Patil, for lovely introduction. It's a pleasure to meet you. I had the privilege of meeting you, and nowadays we are not able to meet friends. It's really leading to lot of mental agony. And I wish and pray this corona goes away. Then we are again traveling, and physical meeting has its own charm. Thank you, everybody. Thank you, Mox. Thank you, Maharashtra chapter, IAG. Thanks for the invitation.
Thank you very much, madam. It was an eye-opener, really. I really appreciate that the surgery you have shown was fantastic. And the most important thing, that you had done a teamwork. You have involved the urologist as well, because a laparoscopic surgeon should know their own limits, that up to what limit we should go and where we should stop. That is really fantastic and really a lesson for the gynecologists also. So, madam, thank you very much for sparing your time and your skills and highlighting all the deep endometrial infiltration, particularly post-surgery counseling. That's very important. Thank you very much for sparing the time and highlighting us. Thank you very much. Over to Niranjan.
Thank you, madam. You have wonderfully described deep endometriosis. Behind every scar, there is an untold story of survivors. And it is such a wonderful presentation, madam. I am still getting requests from all over the country and abroad for you. And there are very wonderful remarks and comments which I would like to read for you. This is Dr. Reena Shrestha from Nepal. Dr. Alka, madam, very academic session of your deep endometriosis. She has also thanked Dr. Shailesh Puntambekar. Thank you from Nepal. This is Dr. Sham Pyari Jaiswar from Jaipur. She has also thanked for your wonderful presentation. And we are in, this is Dr. Madhu Rajpal from Agra. Awesome, crystal clear presentation. So I think, madam, you have done a wonderful job. And there are no questions. I'm sorry, but this is the fact of life, the way you have explained it, and you have given your valuable time. And it's such
I can't leave without making one sentence, Dr. Niranjan. You are too good in this job, and everybody appreciates. Tomorrow I will go. Last time my staff said, madam, the composer was very good. So I felt.
Yes,
but you are really very good in your job.
Thank you, madam. Thank you so much. Thank you, Prakash sir. And I want you both to be there. In case you would be there, I would appreciate. Thank you, madam, for your valuable time. Great speaker, great, superb job, excellent presentation. Even our panelists are saying, Dr. Sanket Prasad, Dr. Nitin Shah, Dr. Rohan Palshetkar have really appreciated. Dr. Ashish Kale, your presentation. You are a guiding force to the young and energetic members of IAG and MAG. Thank you. Thank you
So
so
I,
much.
I didn't know, Niranjan, they all are Maharashtrians are such good liars. I thought you praise and you are a good liar, but they all are good liars.
Madam, they are really coming from the heart and they have typed and they have chatted on the chat. You can see it. Rohan Palshetkar has written it,
I
madam.
can see.
And Sanket Pisat has written and Nitin Shah has written. So it
Thank
comes
you.
from the heart. It
Thank
comes
you.
from the heart. Thank you, madam.
Thank
And
you.
really wonderful presentation. Now,
Niranjan,
without not taking much of your time of the young panelists,
yes.
we would
Niranjan,
like to proceed with the young panelists which are there. And I hope you can see my screen. Kindly acknowledge.
Sir, we can't see you.
No, sir. We can see you.
Yes. I hope you can see now. I hope you can see now.
Yes.
Yes.
Yeah, this is not in any particular order. It is not in any particular order. I think we have given all the cases. So, Dr. Nitin Shah, you can start reading your case.
Yes, sir. A 28-year-old infertile patient married since 2 years presented with intense pain in hypogastric region and right iliac fossa for 7 days. History of chronic pelvic pain related to the menstrual period for 1 year with worsening of symptoms in the last 4 months. Physical examination, normal vital signs, no fever, flat abdomen, presence of bowel sound, pain at deep palpation of the hypogastrium and right iliac fossa, absent of peritoneal signs. Vaginal examination reveals retroverted uterus, fibroelastic colon, intense pain at uterine mobilization and a palpation of the posterior and right lateral cul-de-sac. Right adnexal mass palpable, tenderness present, size approximately 5 by 6 centimeter in size, cells separate from uterus. Pelvic ultrasound, normal size of uterus with small quantity of free fluid in the uterine cavity and right adnexal endometrioma measuring around 5 by 6 centimeters. So now question to me is what will be the diagnosis and management approach and what will be the role of medical management and what will be the laparoscopic management. So diagnosis is obviously with the history and USG finding the diagnosis is classical of endometrioma with severe dysmenorrhea and patient is also infertile. So definitely if she is not planning immediately, we will go for the medical line of management. But if she is willing for surgery, we will go for the surgery because she is infertility also. So with laparoscopy, we will try to do adhesiolysis, relieve the adhesion as much as possible and remove the endometrioma. Now it is a 5 centimeter endometrioma. So would like to inject some amount of pitricin on the back of the uterus and in the ovarian cyst wall and remove the with the partial, we will do partial cystectomy, that is Jack Dones modified theory value, remove the entire cyst wall except near the hilum. And the hilum part is left behind and done superficial fulguration. So this is how we would like to manage in respect of to preserve fertility also. So partial cystectomy is a choice which should be done because overzealous cauterization near the hilum will hamper the AMH and reduce the ovarian reserve. So we don't want patient to land up with ovarian failure or decrease AMH following the surgery. So we do careful dissection. Use of vasopressin will reduce the use of energy source. So that is very good. So I think the video is also self-explanatory. You can do partial cystectomy. And depending on after this, we would like to give one GnRH or a Dinogex for a couple of months so as to disease load is reduced, and then we can post her for the fertility enhancing treatment like ART procedure, either in the form of IUI. We do tubal testing also during this procedure, and tubes are patent and anatomy is not distorted. IUI will give very fantastic result in such cases. Over to you, sir.
Yeah, please, you can continue the commentary.
Yes, sir.
So may I add something to this?
Yeah, please.
Yes, sir. Yes, sir.
Yeah, so Nitin Shah sir, I think it was a very well said thing about Donez's technique of partial cystectomy. Definitely, by not cauterizing at the hilum, you're actually preventing any damage of the primordial follicles.
Follicles, yes.
The main thing is what we want to also do is probably check the AMH prior to surgery,
Prior to,
so that we do
yes.
know the oocyte, the egg reserve prior to surgery. And if it is a possibility and the patient say does not want to conceive anytime soon, the option of oocyte freezing can be given to her, and then later on she can try naturally after the medical management if she wants to. Otherwise,
Yes.
as sir said, after treating, this looks like a very clear cut case where the anatomy looks very
Yes.
the
Ron, this
anatomy
will
looks,
be what you are telling ovarian freezing. It will be severe cases in bilateral endometriosis. We do that, but this was a clear-cut unilateral endometrioma, and
absolutely.
opposite side was absolutely normal. So, but there is a really good take-home message. People really don't think in this line of ovarian preserve. So, very good point you brought it out, right, dear. That people should counsel about ovarian preservation before the surgery. AMH we do by default for all the patient of
Absolutely.
PCOD and endometriosis before surgery. But ovarian preservation, yes, we need to speak more about it nowadays.
Yeah, I think
Yeah,
Ashish sir wanted to say something.
wonderfully explained by both of you. I agree. You have to use less of coagulation and less of burning and charring the ovarian tissue. There were use of bipolar cautery or use of laser. This was a video which we had done in high grad presentation of our online courses. And Rohan, you have made a valid point regarding the AMH and also post-operative AMH. And Nitin, you had told about the use of leuprolide and GnRH. So, would you like to give post-operatively also on this? Would you like to just add your comment? Then we can go ahead with the next case.
Immediate post surgery will down regulate for 1 or 2 cycle, and then you post for the IUI treatment, and they respond very well.
Okay. I request, yes, Ashish, I will give it to you. I request anybody who would like to give their expert comment, please raise your hand so that I can see, and then I will call you. Thank you, Dr. Ashish. So nice of you. Please go ahead.
What I feel, sir, what Nitin is talking about giving a GNR channel lock, if she is having a unilateral endometrioma, it is better to make them a spontaneous conception for at least 6 months. You have to wait for after the surgery, because there are the case reports, there are the series like within the 6 months, the spontaneous pregnancy rates also increases. So if you give a GNR channel lock, you are making it suppress for 1 month or 1.5 months of amenorrhea. And later on, if you want to stimulate, you require a higher amount of gonadotropins. So if what is the age of the patient, what is the need of the patient, that has to be taken into account.
Yes, Rohan.
Yeah, so in fact, that's exactly what I wanted to talk about. What Ashish sir said, that if we do end up giving agonist for 2 cycles of down regulation, the amount of gonadotropins that would be required, because in endometriosis we know that gonadotropins when combined with IUI would give a very good success rate. But if you do allow them for spontaneous conception, because in this case I don't think we know how long is the period of infertility as well. So whether to give them a trial of natural conception or whether to consider ART treatments would be a decision to be based not only on the egg reserve but also the duration of infertility as well, sir.
Great, wonderful. Oh my God. Actually, COVID has made us to visit all our subjects back again. And maybe whatever your age is there, we are just going through whole of the textbooks, what we did not do for probably in our last 25, 30 or 15 years of practice. Sanket is slyly smiling and looking at us.
Just admiring, sir. Just admiring.
Yeah, thank you. Okay, now I will go with the case.
Can I add one thing?
Well, I hope you can see my slides.
Niranjan sir, I think Prakash sir wanted to say something.
Yeah, please, sir, please
Yes,
go ahead.
in addition to what Rohan said is that after the surgery, we should go for spontaneous or IUI. I think we prefer to go for IUI rather than wasting time. after doing AMH. But can we tell the patient after 3 months, 3 to 6 months, to go for the second look laparoscopy to see the tubal patency after the surgery and then go for the IUI? This is a discussion. Anybody can opine on
Yes, Ashish.
No, generally they will not be so much eager to go for the second surgery, sir. There will be always a reluctance from the patient point of view because they won't be readily go for the second this. They will ask for the non-invasive technique for tubal patency, either sonosaline histography or histography, sonography or histography.
Yeah. Tubal patency tests, some tubal patency tests like HSG or sonosalpingography.
Yes. But repeat
Thank
surgery,
you.
they won't be agreed.
Yes, Ashish, that is the last comment. Then we go ahead with our presentation. We have got 5 more cases to be discussed.
In endometriosis, the tubal affection is not that much. So usually in majority of the cases, the tubal patency is a patency test is a positive. So tubes are not going to affected as a patency test, but tubo-ovarian angle may change. So tubal patency per se that much important.
Well, thank you so much. Now I call upon Dr. Rohan Palchetkar. We all know he is an assistant professor at Dr. D.Y. Patil. He is a member of the managing committee of MOGS. He is also the member of the managing committee of MSR and SR. And presently he is a joint secretary of MOGS. I think more than this introduction, we all know that he is a very good dancer and he has got very good sense of humor. I think that completes his CV.
Thank you, sir. Thank you for your kind words.
So I think let's go without wasting much time and we will go ahead with your presentation. Thank you. Please go ahead.
So we have a 22-year-old unmarried girl with a case of severe dysmenorrhea. She's consulted many physicians and an MRI is showing bilateral endometriomas of 5 centimeters. The uterus shows an adenomyoma of 4 by 5 centimeters. How would you manage this patient? So this was a case which had come to me after almost seeing about 4-5 other physicians and then come to me with complaints of severe dysmenorrhea, and it used to be quite debilitating for her. So the first thing what I wanted to do was, obviously being an infertility specialist as well as endoscopic surgeon, I first wanted to ensure that her ovarian reserve was good or not. So first thing I would do is definitely check her AMH. Obviously, the treatment option would be considering surgery for her because she's having severe dysmenorrhea. And with that, I would probably give her medical management post that treatment. But again, as I mentioned, even in the previous case, in such a case where a 22-year-old, because this is going to see the MRI is showing bilateral endometriosis of 5 centimeters and adenomyoma of 4 by 5 centimeters. I'm sure all the seniors on this panel will agree that it's not going to be such a clear-cut picture when you actually enter the abdomen. When you do enter the abdomen, it is going to be really stuck up and it is going to be quite an extensive surgery for her. So she did not want, so at the end of the day, I did her AMH. She was not interested in oocyte freezing, even though the ovarian reserve was already low for a 22-year-old, and she was refusing surgery. So in this situation, I ended up giving her Dynogest 2 milligrams, and she has gotten relief from this from the dysmenorrhea. Obviously, I had to explain to her that the side effects are that there will be amenorrhea while she's on this medication, and she has to be careful to not miss any medication because any breakthrough bleeding can cause more severe dysmenorrhea as well.
Yeah, please. Yes, Dr. Abhishek and then Sanket.
What is your plan for the adenomyoma? Resection or not?
I would want to do the resection for the adenomyoma, but obviously, with the patient's consent, if she's not agreeing for surgery, for now, we have to end up doing a medical management for this situation. But ideally, what would be the actual solution would be surgery, because it's clear-cut case where there is severe dysmenorrhea and maybe a clearance of the endometriosis with the medical management would probably help her the most.
Yes, Dr. Sanket. And then Ashish.
Yes, sir. I think I tend to agree with Rohan in the fact that I would also try and prolong her surgery for as long as I could. The reason being that no matter how good you are at your surgery, bilateral endometriomas of 5 centimeters and adenomyoma of 5 centimeter is going to recur after your surgery. Either it be in the next coming year or a few years later. And so I would rather give her medical management, see her ovarian reserve, and try to prolong surgery until such time that it is unavoidable, and then operate once and operate properly, preferably closer to a time when patient is actually planning childbearing. So that would be more beneficial rather than going in again and again and decreasing the ovarian reserve by repeated surgeries until a point that ovum donation becomes necessary. That would be my take.
I have a comment on that answer, Dr.
Yes,
Prasanke.
next.
So she's 22-year-old, she's unmarried, she's not expressed any desire to get married or have children, so that is her choice at the end of the day. We are working on a big assumption and a leap of faith. She has pain currently, those are her current symptoms. She wants that resolved. If there is already a problem that is identified with 2 cysts, and 2 cysts, the incidence of 2 cysts having deep endometriosis is 90%. Apart from the adenomyoma, there's going to be infiltration of the uterosacrals, which is causing the pain. A cyst by itself will not cause pain. Only when it infiltrates laterally and catches your nerves is when you're going to get your pain symptoms. Also, she will have pain because of the adenomyoma. So Rohan correctly said we will require to do an adenomyoma resection. Then the point of drawing it out and keeping her in pain with disease pervasive and infiltrating throughout that time, because medical management is only symptomatic therapy. It's not going to, there's no proven evidence that shows that it stops the growth of disease. It stops symptoms, but it will not stop growth. So this is what your current scenario is. God knows what it will be 5-10 years down the line when she does decide to get married and have children.
So may I ask that if this disease and her symptoms are getting controlled on medical management, you would still advise surgery at 22 years of age for this patient?
Yes.
Okay, I beg to differ with that point then.
It's okay. Okay, I think fine. Now, Dr. Ashish.
Yeah, sir, it is very well given in a guidelines. You follow any guidelines. The adolescent girl, symptomatic, medical line of a treatment. First medical line of a treatment, it fails. Then you think of the surgical treatment. Here, again, the Dynogest better option because it's oral. But you may think of putting a Mirena because that can be one of the choice. If she is sexually active, unmarried doesn't mean that you cannot put. Because that will again take care of adenomyosis very well. If you compare between the Mirena and the Dynogest, we don't have a comparison in relation to the adenomyoma. So that medical line will be a first line, then the surgical, because the surgical, even if you do a surgery, you never know when you are going to repeat it again because it's a recurrence.
She might land up with a recurrent endometriosis and it might just continue. By 30 years of age, she might be having 2 to 3, 4 surgeries. We don't know.
Absolutely.
But such patient need to be monitored because they might land up with rupture of endometrioma. So we need to carefully follow up this patient because I have seen at least 4 or 5 patients who have come with rupture endometrioma with acute abdomen, even young unmarried girls. So we need to monitor and they should be constantly under follow-up. That is very important.
That was my next point that she has been.
But 5 centimeter, don't you think it needs surgery? Maybe it's 2 or 3 centimeter. We could have just given a medical line of treatment and left it alone because it's filled with blood.
So
Abhishek?
Yes. So I'm very outright that this patient requires surgery. There's no two things about it. And there's a big misnomer with recurrence rates. Recurrence rates occur. I mean, the actual recurrence rates when you do proper excision of disease, the highest reported recurrence rates in literature are only 27%. There was one study in the 90s that reported 40%, but that was very invalid in its methods and materials. So with a 26% recurrence rate at the worst is not a terrible scenario to offer to this patient. Yeah, there's 1 out of 4 chances that she might require another surgery, but 3 out of 4, she will be pain-free and be able to achieve whatever she wants to in life.
Okay, next is Amay. After that, Amay. Then after Amay, Rohan.
I agree with Abhishek because see, her primary symptom is dysmenorrhea. To tackle this symptom, you have to reduce the load of the endometriotic lesions and it requires surgery. prima facie with bilateral lesions also, unless the patient refuses and resorts to medical line of treatment. Of course, the guidelines do mention the non-invasive methods first, but clinically we have found that symptomatically they respond best to surgical excision.
Okay, Rohan now.
Yeah, so sir, ideally, I had offered her surgery because it was such a bad scenario where she was having so much pain, but the patient herself was not willing to undergo surgery. So we ended up giving medical management, and
I
she has
agree.
been.
Most of these girls, 90% of them who come to me also, they come with their fiance. They tell that they want to get married, and but the problem is that the pain, they can't tolerate that pain of dysmenorrhea and during probably intercourse, probably that's what I assume, and even in PV examination, but they are afraid to go for a surgery. That is what I have seen. Absolutely, where your role of medical line of treatment. So I just want to tell you, but how much time are you going to give her the medical line of treatment? 1 year, 1.5 year? Because this thing is not going to get resolved. 5 centimeter, it might just reduce by itself.
So
So how much to pull on? Let's
Yeah.
have a clear cut message.
There have been papers which have shown that Dynogest can be given up to 3 to 5 years even. So if on Dynogest she is having relief, then in that situation, I don't think we don't have to worry for quite some time. But eventually beyond the point, if with the follow-ups, we have to see if these endometriomas are enlarging, if her symptoms are still under control. So I think till she is mentally ready, we'll have to continue on medical management as long as we can, and beyond the point, then we may have to just consider switching our medical management to eventually decide what to do, because now there are oral antagonists as well which are coming in, like elagolix, which have been shown to improve symptomatic treatment for endometriotic patients as well.
Now, Rohan, I wanted to be specific. You said 3 to 5 years. 3 to 5 years is very long time, but practically not possible. Even Abhishek and I and Amay Padmavar would not agree with what. But I just want to tell you, but in case you would like to give her an option and she is reluctant to go ahead, and we don't want to do something where she doesn't want to undergo, and I don't want to lose that patient also.
Yeah.
Imagine. So with this scenario, practically, I wanted to tell the dose and maximum how much you would like to pull on, and then of course you would like to take her for surgery. Let's be practical and let's give a take home message so everybody has a proper consensus amongst all of us, and I hope everyone will agree with that. Maybe I might not agree, maybe Abhishek might not agree.
So practically speaking, right now she's on Dynogest 2 milligrams once a day, taking in. I would at least, my personal thing is I'm just going to be following it up with her every 3 months and take it 3 months at a time. Eventually, every time I do meet her, I keep telling her that, look, these are only symptomatic relief. This is all that's going to give you symptomatic relief. It's not going to really cure the disease. Eventually, if you do want complete resolution, we have to end up going for surgery. So I think at the end of the day, it has to be a good dialogue between the doctor as well as the patient to finally decide the management. But as far as possible, if I look at a time limit, I would say approximately 1.5 years to 2 years, I would stretch the patient if she is not willing for surgery.
Maybe she would like to marry. Would you like to operate her before marriage or after getting married?
So when she would decide to conceive is when I would think of then finally telling her that start going for surgery. I don't think it's in our purview to tell any woman right now that get married and conceive early, because that's the best possible treatment for endometriosis. But in that situation, as I said before, oocyte cryopreservation could be an option preceding surgery.
Ashish, your last comment, then I move on to the next case.
Sir, rightly, we are discussing very in a
gray area. We are going through a gray area.
But what I feel, it's just a time buying. We are buying the time from the patient.
Buying the time is the right word.
That is the only will be a way forward. Maybe a 6 months, 8 months, but she has to go for the surgery.
I absolutely agree. I think the general consensus, we are agreeing. And thank you, Dr. Rohan. It was a wonderful discussion. And
Niranjan, can I add one comment?
Yes,
one comment.
Yes, sir. Please.
Yes, what Rohan said is right, absolutely. But at the same time, counseling of this patient is very important. If we are delaying the surgery with Dynogest, certainly are we going to compromise in her ovarian reserve? Because after spending so much of time, 2 years or 3 years, once she will be operated, her AMH will be very low, her oocyte quality will be very low.
Yeah.
And are we subjecting her for IVF after that? The patient is going to blame us. So certainly we should do the treatment, but counseling of the patient that yes, slight compromise in ovarian reserve will be there if we delay the surgery. That's what I think somebody can add to it.
So absolutely, I agree with you on that. And she has been counseled, and I her AMH is extremely low as it is. So at any point, even if she does end up going for surgery, it is going to be much lower. It's already, I think, I still remember her AMH when she came was 0.3. So I think at this point, AMH is a moot situation in her case. But at the end of the day, we still have to provide the treatment. But I completely agree with you that counseling of patients who would have a
Very
good
important.
AMH is very important. And we have to explain to them that if we wait that long, your quality and your oocyte reserve is going to decrease.
Yes, yes, right.
Yeah. Okay, fine. I think wonderful. With that, we will go ahead with the next case. And I call upon Dr. Abhishek Mangeshikar. Well, he just hold on. I want to introduce you.
Still with MGM?
Yes, so I've not been there for 4 months now because of COVID.
Dr. Abhishek Mangeshikar is an MS diploma in pelvic endoscopy in Germany. He has also gone to Taiwan and he has done his fellowship in minimal invasive surgery. And I find him to be quite brilliant. I met him many times in between. And he is the founder and the director of Indian Center for Endometriosis, Clinical Director Mangeshikar's Magic Center for Women. He is a visiting professor of advanced gynecological endoscopy in University of Kiel, Alexandria, Egypt, IRCAD, Taiwan, and he is a consultant gynecologist, endoscopist at Bridge Candy, Saifi, Jaslok Hospital, Vokard Hospital. He is also the honorary gynecological endoscopist at Nauroji Wadia Maternity, faculty at CMAST, and an international gynecological cancer society traveling scholar. He's also been the board member of the Young Apache group. I think that is a remarkable achievement, Abhishek, at this such a young age. And I would like now you to please go ahead and read your case. Thank you.
Thank you, Dr. Niranjan, for a very kind introduction and for inviting me to be a part of this panel. So my case is a 24-year-old married patient with severe dysmenorrhea and post-menstrual spotting since 5 to 6 months. She has a history of menstrual pain progressive since 5 to 6 months. The pain is especially severe around the time of her periods to the extent that she cannot concentrate on her work and daily activities. She has tried numerous painkillers and COCs without much relief. Ultrasound showed bulky ovaries adhering to the uterus in the fundal region with 2 by 3 centimeter endometriomas, 2 by 3 centimeter right endometrioma with ground glass appearance and pelvic peritoneum adherent with the surrounding bowel, likely suggestive of peritoneal seeding. MRI shows findings consistent with deep pelvic endometriosis with peritoneal thickening with multiple loculated hemorrhagic and non-hemorrhagic collections in the periovarian region bilaterally suggestive of a right-sided 2 by 3 centimeter endometrioma or a chocolate cyst. Endometriosis seen along the serosal surface of the anterior rectum and the posterior superior wall of the urinary bladder, suggestive of pelvic endometriosis and involving rectal. Now, just a couple of points, if you can go back to the previous slide. I know this is for a presentation, so it has to be summarized, but what I want to get across is that endometriosis, when you see a patient, the consult, just the history taking takes about 45 minutes. So you cannot summarize in this. For example, I would say, how long has she been married for? Is she trying to conceive? Any fertility issues? Then her complaints of severe dysmenorrhea. What is the visual analog score? Is it pre-menstrual? Is it menstrual, post-menstrual? How many days out of 30 in a month is she incapacitated for? So what is her quality of life index? Then she has since 5 to 6 months. Was it a sudden onset? Are there any alleviating or exacerbating factors for the pain? What painkillers and what COCs have she tried and for how long? Now coming to the ultrasound and MRI. First, this is a very incomplete ultrasound report, and the MRI, what I have a problem with is the nodules, they're not mentioning the sizes. So that changes your decision making a lot. So one is I would never refer a patient again to this radiologist and sonologist. Okay, but assuming everything is as it is, and so the PV findings is what I'd like to know. Is there any infiltration into the vagina on the posterior fornix? So you need to do a speculum exam for that. Now, when you look at the MRI, I don't look at the film. I don't look at the report. I look at the images. So I go through it and I make my own diagnosis there. And I also perform my own ultrasound. So then you need to check for sliding at the uterine torus, where the uterosacrals are inserted. You need to check whether they already identified that the ovaries are adherent. And whether there is fibrosis in the uterosacral. So when you turn your probe laterally at the uterosacral, at the torus, you'll be able to see either a dark endometriotic nodule or you'll be able to see a white fibrotic lesion there. So that should give you a clue to your diagnosis when you're doing. And then the MRI, you need to instill gel into the vagina and the rectum and take 1 millimeter slices so you can identify if there is a lesion that is involving the vagina or not. So that is going to make a decision whether do I do a colpotomy or not during my surgery. Now coming to the questions, can we go ahead? Okay, so first is how will you manage this patient? So it's very simple. She needs surgery. I've diagnosed disease causing severe debilitatory symptoms, ruining the quality of life. So she needs a laparoscopic excision. So based on this information that we have, first is you do a laparoscopy, you survey the abdomen and pelvis and map all your endometriosis. Then you start with your bilateral ovariolysis and suspend the ovaries. Then you have to bilateralize your ureters. So dissect medial to the ureter and push it laterally, not like cancer where you go in from the lateral approach medial. And then I've developed both the lateral and medial pararectal spaces. Now, if there's a vaginal infiltration, I will do a colpotomy with one finger in the vagina and use a harmonic to make my colpotomy to drop the entire nodule onto the bowel and then develop the pouch of Douglas behind that. If there is no vaginal infiltration, I will, after opening both my pararectal spaces, and in this, you will not go lateral to the fat, you will go medial to the fat towards the rectum. So you use the rectal serosa as your marker. The rectum is got a good layer of what serosa, the peritoneum around it. So you're not going to damage it. And then once you do that, then you can drop the midline adhesion down. So if you directly go into the midline, you're probably going to open the rectum. So once you develop your lateral spaces on the rectal dissection, that is when it comes easily off without damaging the rectum. Then depending on what kind of nodule it is, if it's just involving the serosa and it's a small nodule, yeah, you can get away with shaving. But you must remember that no matter how good you are at shaving, and you're always leaving a degree of fibrosis behind. Now, whether you believe that degree of fibrosis causes recurrence or not is going to base your decision on whether you're going to shave or whether you're going to do a discoid excision. That is the only thing for that. Bowel resections are becoming less and less common nowadays. If there are multiple lesions of the sigmoid involvement, that will make you do a bowel resection. Or if there's a huge nodule infiltrating that will not fit in a circular stapler, to do a disc. So the nodule by volume should be less than 8 cc in the dimensions. So that's what your imaging needs to measure the nodule in 3 dimensions and then give you the report. Also, they need to tell you the distance from the anal verge, because if you're opening the vagina at the same time and you've got 2 overlying suture lines, then your risk of rectovaginal fistula is a lot higher, and then you have to maybe counsel for a colostomy. Okay, coming to the bladder nodule. What is the size of the bladder nodule is what I'd like to know. Then I would do a cystoscopy to assess and stent the ureters if required. And obviously, I don't believe in shaving the nodule through a cystoscopy. You will do a laparoscopic, open the bladder and resect the entire nodule and do a 2-layer or 3-layer closure, whatever you're comfortable with. Make sure it's watertight. Finally, at the end of this, I will do the cystectomy if possible. It's a small endometrioma, but when I free it, the endometrioma anyway ruptures. So if there's a clear margin, I'll remove it. Otherwise, it's not really necessary. Depending, as Rohan correctly mentioned, that you would do your AMH and look at your ovarian reserve before the surgery. Then also you would excise all peritoneal implants and any infiltration into the uterosacral as possible. If there's deep parametrial, you have to be able to make sure that you don't damage the nerves, and probably you might want to be more radical on one side and slightly more conservative on the other. Now, what is the role of Dynogest in chronic pelvic pain due to endometriosis? There is no role of preoperative Dynogest except if you want to delay the surgery, and I'm free in September, so I will not delay the surgery. So post-operatively, yes, if I'm doing an endometrioma only, then I will give 3 to 6 months of continuous OC pills so she doesn't ovulate. Because if I've got the ovary that is resolving or healing, I don't want bleeding to occur within that ovary to form another hemorrhagic cyst or something to complicate matters further. So post-operatively, not to prevent recurrence, the medical therapy doesn't prevent recurrence, it may just prevent symptoms. And in my opinion, it is only to prevent anovulation in case of ovarian endometrioma. Do you suggest to start medical treatment and do USG after 3 months? No. And if the response, okay, so I think that's my summary.
Well, I think the discussion part has been done wonderfully by Dr. Abhishek Mangeshikar. I kept a very difficult case for you purposefully, reading your CV and the exposure and experience which you have taken in Germany and Taiwan. And today I can say, when I meet you not in person, but in a webinar, that you have really grown up. What I saw you 2 years back when you had come to Sion Hospital, and the amount of exposure which you have gone through in Taiwan and in Germany, I think you have given a wholesome, total approach to this patient. I purposefully did not keep certain signs and symptoms and certain calculations of the size so that you have to go through it. And the best part, I will tell you everyone, this case I discussed with Horace Roman. I hope he is the father of rectovaginal nodule surgeries, and he does even colostomy and disc dissection through the anal canal, and even those pictures. So we have a film, but due to shortage of time, we will still show it later if we have time. Any other member here would like to say? First Rohan, and then Dr. Prakash Patil, then we move on to the next case.
Abhishek, I just had a question for you rather than anything else. But you talked about stenting when you do a cystoscopy, right? But when you were talking about doing the surgery, would you think of doing the stenting prior to the dissection of the ureters and then, or would you just go ahead and dissect the ureters and later do
that's a great question. I actually had made notes to mention it, but I think in the rush of getting through the case, I skipped over that. So yeah, because I'm going to do the bladder nodule excision last, I don't like stents in the ureter when I'm dissecting. I feel they make the ureter very unwieldy, especially when I'm dissecting the pararectal spaces. So I don't like the stents in early. So we always have a urologist. I mean, I tell them beforehand, so they'll come in when we call them, and then they'll stent at that time. If necessary, if it's a small nodule, then you don't need to stent also. Yeah. And if it's away from the trigone.
Yes. Abhishek.
Yes.
Again, I can see Prashant in you, a mirror image, equally blunt and very straightforward, and stick to your opinion.
Sir, you will see Prashant in him only.
Because there is a reason, because I learned laparoscopic surgery from Prashant. I used to go all the way from Nagotane, small place, to his place early at 5 o'clock, and he used to teach me. So I see Prashant in him, equally blunt and straightforward. I really appreciate that. That is one thing. And
he's a mellowed version of sir.
Yes, exactly. That's what. But really appreciable. He doesn't bother about anybody. So differing from the opinions. That's something very clear and straightforward.
Very nicely.
I really appreciate that. And I just wanted to ask you one thing, that when you are doing such a difficult surgery, do you always keep the surgeon and urologist standby just to
No.
avoid the complications intra-op or post-op?
No, I don't call the urologist usually unless we're doing a reimplantation or something. So just ureterolysis, even if there's an injury, I can repair it myself. But if there is a bowel procedure required and a stapler has to be fired, then by law, I think it's very important to have the colorectal around as the backup also, because they will make the decision whether the anastomosis is good, whether she needs a colostomy or not. And that's not a problem I want to deal with. I'd rather share the concern with someone else.
Good, that's great. Thank you very much.
Thank you. Thank
Okay,
you so
Niranjan,
much.
over to you.
Thank you, sir. There are many questions which are coming. People have gone crazy. We have crossed more than 1,000 users, and they are really amazed with the amount of quality of the transmission, the audio and the video quality, plus the discussion which is going on, starting from basic anatomy to endometriosis. And now we have already discussed, Doctor, case number 3. So I will like to go ahead with case number 4. And this is Dr. Ashish Kare. Ashish Kare is presently the office bearer of Pune Obstetric and Gynec Society, and he is also a member of the MSR and also the ISR. He is the most popular guy amongst all the passionate Foxians which we see. And to be more on the serious side, he has his own center. He is an IVF specialist, more of in Pune. I met him many times, and that's why we are meeting today in webinar as an examiner also at CPS, DGO, and at various conferences. He has his own practice at Asha Kiran Hospital. As I said before, he is already a member of even ISAR and ISGE, and a very simple and humble man. He has done his diploma of endoscopic surgery in Germany. And Dr. Ashish, we all know that in webinar in COVID times, you have got your big show, Facebook Live, and there are many members who join there, and you have got big luminaries who have come, and we are very happy that today you have accepted this invite and to be with us. So please, with this introduction, I request you to please take over and start your case. Please read your case.
Thank you, Niranjan sir. At the outset, I'm really thankful to you for giving me such a chance to talk to you, and I congratulate you on your victory in Foxy, and also I can congratulate in advance for your victory in IIG. 34-year-old married woman came to my OPD. She has a AMH of 1.8. Came to the clinic with a history of complaining of infertility. USG shows a 4 centimeter endometrioma, and she had already undergone the 3 cycles of IUI, which was failed. And now she is wished to conceive other hormonal parameters like what we do in day 2, like TSH, prolactin, and all. The hormonal test seems to be normal. The semen analysis has been done and shows that it is a mild oligoasthenospermia, and that's why she had undergone 3 cycles of IUI. Pertaining to that, how will I manage this case? That was the question. But then I had gone through the details of IUI procedures, what she had undergone with. First 1 or 2 cycles she had undergone with the letrozole, and with that they found out that there is a ovulation which is documented, and the IUI has been done. The IUI pre-wash sample showing it is a 55 million count, and the post-wash it is somewhere around 30 million with the 90% of the motility. The third cycle, the same gynecologist given a gonadotropins with the letrozole, and somehow it is again the failure, the patient not conceived. The third time they are only started with the gonadotropins, and with the dose of 150 international units of recombinant, and with that they add up also in order to prevent the premature LS surge, and they had done the IUI because all of us knowing addition of the antagonist will increase little bit chances of pregnancies in IUI cycles. So they had done that. Now that particular thing is also been failed, and she had come down to us with the AMH of 1.8, with the endometrium of 4. Thinking the history like this, I think there is no point again to go with the IUI, or maybe for that matter a surgery in this case, because the endometrioma is 4 centimeter. I like to do a transvaginal scan of my own. Why? Because on day 2 I will be knowing what is the AFC first of all. Secondly, I'll know what is the location of the endometrioma, whether the endometrioma is coming in my stimulation protocol and the OPU procedure, and then I'll likely to stimulate this patient with the recombinant FSH with the 225 in the antagonist protocol, because AMH is 1.8, so I don't want it to go with the down regulation with the GNH analog and then pumping up with the gonadotropins. So it's a straightforward gonadotropin and with the antagonist protocol.
Sir, then kindly tell the dose. Ashish, please tell us properly the dose, everything.
I will start with the 225 recombinant FSH, and I will start with the fixed dose or maybe a variable dose of an antagonist. Usually the fixed dose will be a day 6 of a cycle, or maybe when the leading follicle becomes a 14 millimeter, we start with the Cetrorelix 0.25 subcutaneously. In these patients, I will like to go for a dual trigger. What I mean by the dual trigger, I'll be give a triptolin 0.2 with the recombinant SCG 250 international units and do the OPU maybe 1 day later. And I will cryopreserve all the embryos which I'll get out of this particular stimulation. Then definitely after the next cycle, I'll reassess the endometrioma again, and I will reassess the endometrium thickness in this stimulation cycle. Because why I'm going to do that, whenever I'm going to put the patient of gonadotropins or maybe a stimulation, I'll also make sure that the endometrium is properly growing. And at the time of the OPU, I'll be doing the mock ET also in order to know my way whether that endometrium changes the uterine axis, which will make my embryo transfer difficult. I'll be having that information prior. And if that is the problem, then I'll likely to operate this patient, make the anatomy correct, and then do a TOG ET later on.
Absolutely. You know what? I'm getting so many messages. People have already started asking recording of this webinar when this webinar is not over. I mean, I can't believe this has never happened in my 50 webinars till now, and I am not joking. We should have part 2 of this program. Rohan.
Absolutely, sir.
No, I'm really serious.
This is a Pranab effect.
I don't know. It's nothing to do with me. People have got bored of me actually now.
No. Sir, I disagree. Your charisma.
No, absolutely. When they are hearing Ashish and Abhishek Mangeshikar and Amay Padmavar, Sanket and Nitin, amazing. I'm really impressed. We have got many questions. So we are going to come back again. Rohan, you have to get ready. Maybe after 15-20 days, part 2.
Yes,
that will be probably after going all throughout India. We will come back, but we need to get this. We have to see. We have to understand there are many people who want to do surgeries. Absolutely. They are not endoscopists. That's why the whole theme is endoscopy for all, and endoscopy for all and every gynecologist. And we have such a brilliant, people who are there. Abhishek Mangeshikar from Taiwan, diploma, Germany. Even Amay, Ashish has gone. You have been trained, Rohan, yourself, with Dr. Shailesh Puntambekar. I remember even Rohan Krishna Kumar. There is Anurag Bhate, Nitin Shah, who has come from GS. Sanket has gone to Europe. Sanket, we are going to come back to you. So it's really amazing. We want a lot of different things. So we will come back. I think, Ashish, you have done a wonderful job. Thank you. We are going to go to the next case.
I think Rohan wants to say something.
Yes. Prakash Patil, sir, please. Yes, sir, please.
Just in the previous case, what Ashish sir said, absolutely, I completely agree with him. Just a couple of things. While doing the OPU, we need to be careful that we don't puncture the cyst.
Yeah.
Just in case we do puncture it, I thought I should add that to it, that we should remember to change the needle for the OPUs and after you finish the procedure, keep the patient admitted for at least 24 to 48 hours for IV antibiotics. Because if you do rupture endometriotic cyst during a pickup, there is a risk of an ovarian abscess. So therefore, we have to ensure that we do give them a good antibiotic coverage, IV for maybe at least 24 to 48 hours, and then only discharge them. Another thing, sir, Ashish sir, I differ from you a little bit. Of course, I agree with you about the freezing, but after I freeze them, I would have given maybe 2 cycles of agonist depot, and then considered a frozen thaw ET for her, because maybe that would improve the endometrial lining and reduce the endometriotic load and the
That's
endometrial.
why I was told about the endometrium lining you should be doing during the stimulation also.
Absolutely, sir.
Yes. Sanket.
Yes, sir. If I could just have a minute, I had a slightly different point of view.
Sanket, you'll have to speak little louder, please.
Yes. Is it okay now?
Yes, now, that's fine.
Sir, I had a slightly different point of view. Maybe it is because I am not an IVF specialist myself.
Same here. I am also not an IVF consultant, but purposefully, I got 3 IVF. Dr. Prakash Patil, the big boss, Dr. Ashish Kare, and Rohan of DY Patil, and his own Bloom IVF centers.
No, sir.
This is what I want, a tug of war between IVF and Endometriosis and Nitin Shah.
If
and
you are
Mangeshikar to come in between.
Sir, if you are on my side, then we will take on all the panelists together. So my prudent question was, sir, just not to this thing anybody, but my question was, she's 34 years old, she has an AMH of 1.8, and there is a 4 centimeter endometrioma on one side. I presume she has not undergone surgery. Now she has gone 3 IUI cycles before, which have failed. So one is where the IUI cycles have been done, whether they have been done properly or not. There is some oligospermia. So fine, let's keep that aside. But my point of contention was, she's 34 years old. There is a unilateral 4 centimeter endometrioma. And endometrioma is not just an endometrioma. An endometrioma has got a severe distortion of tubo-ovarian anatomy on one side or both the sides or in the pouch of Douglas. My point is that if this 4 centimeter endometrioma is operated and the flimsy adhesions, not the very difficult grade 3, grade 4 adhesions, but if the flimsy adhesions can be cleared, and if this patient can be given a trial of gonadotropin IUI, is it correct management, or are we living in the past suggesting the patient this kind of management? And is AMH 1.8 and 34 enough to directly go to IVF, or can we still try with more IUI correctly done and after surgery?
Okay.
Can I add to it?
Prakash, Rohan?
Yeah. Yes. I agree with Ashish. Whatever he has told is very crystal clear. As far as age is concerned, already she has undergone 3 IUI. If we suggest her again IUI, either the patient will leave you, or we will have to send the patient to her. Patient will leave you. So what she needs is a result-oriented treatment, and that is IVF. It's not like that I am IVF specialist, so I am suggesting it. It's not like that. But we cannot waste the age, time, and money of the patient, because that is very important. If you keep on insisting her to go for surgery and IUI, patient may not agree unless she is not affording. But I think for this patient, the right choice is IVF. But while doing IVF also, her AMH is low, 1.8. She is unilateral endometrioma. So she should be told that the quality of oocytes may be poor, and you may not get the oocytes, you may not get the embryos, and at such point of time, she should be prepared for home donation, if at all. She should be concealed properly and told, because if she spends so much of money, at the end of the day, if you tell her that there are no oocytes, or the oocyte quality was very poor and there is no ET, she will be frustrated. So in this case, again, concealing is very, very important. I think all of you should agree. Rohan, please.
Yes,
I absolutely agree with you. The practical aspect of what you said is completely true. In fact, it's not just the practical aspect. There is scientific data which is showing that after 3 to 4 IUIs, the success rate does not continue increasing. In fact, it begins to drop down.
Yes.
Another thing, when we're talking about gonadotropin IUIs, here you're talking about a patient who's already at 3 IUI cycles. She's come probably from a different center because she's not gotten any results. When we're talking about doing even if you do a HL scopy, that's going to require money spending. plus when you do a gonadotropin plus antagonist cycle, say you are charging the bare minimum for an IUI like 5,000, but when you go to spend on gonadotropins, you'd be spending somewhere close to around 10 to 20,000 alone on the medication itself. Is it justified to give her a success rate of 15 to 18% at that cost rate when you've already had 3 failed IUI cycles? So at the end of the day, we have to justify the cost versus the success rate, especially in a 34-year-old with an AMH of 1.8, where as Prakash Patil sir said, that the oocyte quality would also be compromised. So at that point, it does become a catch-22 situation. Sanket sir, you're not wrong, because see, in India, the thing is that the patients are paying money by themselves. If you do consider abroad where the government would take care of the cost, you could consider your thought process where we could operate and maybe consider an IUI. But in this situation, I think IVF would be the ideal treatment for this patient, sir.
Right. Okay, fine.
Fine, welcome, thank you. We have got many comments. I would like to read for Dr. Swadhina Bharti Mohanty. Lovely and brilliant discussion by all the panelists. Dr. Vijaya Lakshmi Sheshadri. Yes, she is a very senior Foxian from South India. We have got people not only from Maharashtra or Mumbai, we have got from all across India. Plus, as I said before, it's from Egypt, Nepal, and Munich, Germany, and also from Southeast Asia. This is Dr. Vijaya Lakshmi Sheshadri. Thanks, Niranjan. All the webinars you have been organizing so great and unintercepted. So with this, thank you all of you. We will go to the next case now.
Can I add just one point?
Yes, sir.
If you permit me, sir.
Please.
Sir, and Sanket, there is another theory now. Like after the certain age, even if you require getting a good one oocyte, the number of euploid embryos are going to increase, and then your IVF success increases. So if the age, again we should think of a age. If the age is there, AMH, again, if it is a normal also, we need to have a one euploid embryo. We require to have a 4 to 5 eggs in order to get a one normal embryo. Yes. So we have to think in that line also in certain time. Thank you.
Otherwise, you'll have to do then pulling of the eggs, oocytes. Repeated this. Or post pickup stimulation. What is the new theory coming up?
The dual stimulation could be considered for her as well.
Yes.
Okay. Thank you. Now I will go with the introduction of Dr. Amay Padmawar. Amay Padmawar comes from the same institute as I have come. That was about 35 years ago. I joined this institute. I stay in Andheri and I used to go every day to that place where there were big mills, and I never had gone that side or even central or the harbor side. But then once I joined that institute, I have fallen in love with it, and I'm still in love with that institute, though I am in Sion Hospital for last 30 years. And that is none other than my own alma mater, State GS Medical College and King Edward Memorial Hospital. And that's what most of us have come, those who have been here. And it's an honor that he is a very, Amay is very silent. He is a very soft-spoken person. I know him for a long time, and I had given him many times opportunity, and we have met many times before, but it is my duty to introduce him. He is now affiliated to LH Hiranandani, Godrej Memorial Hospital, and SL Raheja Hospital. He is also a trainer at Ethicon Institute of Surgical Education, that is CMAST, and he has been trained under luminaries, and I have to name them because they are such giants, and they are none other than Dr. Shailesh Puntambekar, Dr. Neeta Verti. You know all that they did the first uterine transplant in India, Dr. George Keksain, and Dr. Arnaud Vatis. So I think that's a major thing where Amay has joined with us today. And I request Dr. Amay to please present his case.
Thank you, sir, for the kind words.
I request you to please speak louder or take your mic in front of your chin.
Yeah.
And speak
so
louder.
I'm presenting the case of a 38-year-old Paris woman who who underwent laparoscopic supracervical hysterectomy and sacrocervicopexy secondary to grade 3 symptomatic apical prolapse 1 year ago. And earlier she was admitted with chronic pelvic pain that started 6 months following the surgery. On vaginal examination, the deep vaginal palpation was painful. And on ultrasound, the transvaginal ultrasound revealed an area of hypervascularization on the sacral promontory. She was scheduled for diagnostic laparoscopy, and a 2 by 2 centimeter solid wine colored hypervascular hemorrhagic lesion was seen on the sacral promontory. So,
Yeah.
Okay. So let us consider. Can I have the previous slide, sir?
Yes, sir.
Yeah. So this patient has undergone a laparoscopic supracervical hysterectomy and sacrocervicopexy for her prolapse, and now she has a painful clinical examination. So see, first thing is this type of surgery is not performed in the Indian subcontinent. This surgery probably has been done abroad somewhere.
Yes, this has been done in France.
Yes, so this is a surgery which is performed in Europe, and of course, sacrocervicopexy is also performed there for apical prolapse. Now, going by the history, the first thing by the history and the examination, I would always suggest a MRI for this condition after the deep pelvic examination reveals pain. So an MRI should reveal the exact soft tissue nature of the lesion. Okay, then she has undergone a laparoscopy where a 2 by 2 centimeter mass has been detected on the sacral promontory. So, the basic primary differential which goes in favor of foreign body granuloma, obviously it's a PEXI which has been performed using a mesh, which may have involved the use of tackers or a non-absorbable suture material on the anterior longitudinal ligament, and that it could be a foreign body granuloma or a reactionary response to that. Or of course, the pain part, there's no finding related to the ovaries. The status of the ovaries is not known. So, we can keep the diagnosis of a endometrioma or an endometrial lesion on the promontory in mind. But mostly it goes in the favor of a foreign body granuloma or a tissue response to the foreign body of the mesh. The management would be removal of this lesion. So that would, you start with the dissection all around it and slowly converge to the area, taking care not to damage the left common iliac vein, which would be lying in, the vicinity. And of course, if possible, we have to consider whether the tacker or the suture has gone through the hypogastric nerves. So a nerve sparing surgery should be done. The nerves have to be identified and the dissection meticulously done. And the whole foreign body has to be excised. So that's the procedure which I would perform. And of course, the apical prolapse needs to be addressed. So in the given options, I would do a removal of the cervix and all the fibrotic tissue around, close the vault, and resort to another way of supporting the apical prolapse. So if it is isolated apical prolapse, pectopexy with another mesh in a more virgin area. So that area where it has not been used in the past may be resorted to, or a native tissue repair or a high uterosacral ligation, suspension of the vault should be resorted to. So we would use Prolene 10 to, plicate the uterosacrals and then eventually anchor it to the angles of the vaginal vault. So that is how I would manage this case.
Yes, wonderfully explained by Dr. Amay Padmawar. And I don't see anybody is raising their hands. Dr. Abhishek Mangeshikar, please.
Yeah, very, very well articulated, I must say. And just one question, which even I was thinking about, I wanted your opinion on it, was you were planning to do a completion hysterectomy and a pectopexy. So would you remove the original mesh in its entirety? And what are the risks involved with that procedure?
See, it's 1 year old, so of course there will be a lot of fibrosis and difficulty in getting the mesh. So it will be removed in pieces, whatever we can, because the the anchoring of the mesh would be on the cervical stump and on the promontory. So there would be less tissue response along the length of the mesh. So that would be possible by dissecting medial to the right ureter and getting the mesh out would be possible. And of course, the rest would go with the cervical stump.
Yeah.
And of course, I would resort to something. What we have been doing is either the high uterosacral suspension, or another option is I would do is a suture colpopexy. We use a proline suture, a number 10 proline suture, which goes through the anterior longitudinal ligament on the anterior surface of the S1, and then it follows the course of the right uterosacral to be anchored to the angle of the vaginal vault. So that is what I would do, because there is a apical prolapse which had warranted, I would go by the indication. I don't know her past history, but sacropexy has been done in the past. So this could be one of the options which would work in as an alternative procedure.
Okay. Dr. Prakash Patil, your comments, please.
Niranjan, as such, I am not a hardcore endoscopic surgeon. I am basically infertility as well as infertility enhancing surgeries and other. But I think whatever he said is absolutely right. But one thing I just wanted to highlight, these type of surgeries were done in Europe earlier. Even I was trained under Dr. Zem long back in 93, 94. At that time, he used to perform the same. They used to preserve the cervix. Just the aim of preserving the cervix was, there is the innervation of the cervix around. If they remove the cervix, the pleasure of sexual intercourse will be lessened. That's what the European they think. So Dr. Zane used to do a surgery called as KISH, K-I-S-H. In that, he used to remove the internal core of the cervix, but he was not disturbing the nerves which were innervating the upper part of the vagina and the lower, which was that used to secure their sexual pleasure. That's what the aim was. So before doing this surgery, have you concealed the patient, whether the counseling was done that this thing may happen with this patient?
Yes, I think, of course, I have not managed this case, but this counseling is essential when you're doing. And of course, one more advantage which we have 25 years later is that we have very high definition camera systems.
Yes.
So we are able to conserve the nerves to a greater extent. And
yes,
we are going to be dissecting in that zone when we are going to remove the mesh. So all along the right uterosacral, which is the path of the sacropexy, we are going to dissect on one side, and the other side nerves are intact, of course. And with meticulous dissection, we will ensure that that care is taken to preserve them.
Okay. That's all, Niranjan.
Thank you so much, Dr. Amay. Amay, I want to ask you one more question. What is those things which are hanging behind you?
Oh, those are all the conferences I have participated in.
Sorry? Those
Yeah.
are the batches.
Yeah.
Batches.
In the last 12 years, whatever educational ventures I have participated in,
Very good.
all are kept.
Yes, preserved it. Yeah, that's great.
Very nice.
That's really
Now,
great venture.
That's very, usually people throw it, People just throw it. And I want to share with you guys, the first paper I presented in Mumbai Obstetric Gynec Society was in 1992, and I have still that batch with me. And I am following Amay Padmawar. Probably he is younger to me by 10-15 years. But last 28, 29 years, I have preserved all those batches, and they are still hanging like the same way Amay Padmawar has done it. They are in my office at Sion Hospital, and whenever people come, even my seniors come, my mentors, they come sometime visiting. They say, Niranjan, ये क्या लगा के रखा है ये क्या है बाजू में? बोला सर ये बैच है. This is the first paper I presented, and this is the last conference I visited last Saturday.
They are the souvenirs.
So those are the souvenirs I have collected. Apart from probably 150 or 160 mementos which are lying everywhere in my house, including bedroom. Apart from that, so Amay Padmawar, that is a very big message to the younger generation. That you have to still, if you really want to make history and you want to keep something a part of your history, because when you look at those batches, it refreshes your mind that yes, you had gone to that particular conference. And even Ashish Kade will agree with me when we had gone to Surabaya, Indonesia, and we had a very good time, and those batches are still there. Thank you so much. Abhishek, you want to say something? I can see the light on your face and that smile on your face. Probably you have the same thing in your house.
No, I'm very. I don't believe in sentimentality. I throw away my badges at the hotel itself. My luggage is very light.
Amay, please come.
Yeah, this was pertaining the previous case, sir. I would just like to ask the panel about whether, or especially the fertility experts, whether they would consider sclerosant therapy for that unilateral endometrioma.
So
what is the recommendation?
Currently, there's quite a dilemma about it right now.
Yeah.
It's advised not to really do any sclerosing therapy because it does have a chance of recurrence is also there with that. But there are now a few studies which are suggesting that it can be used, but still I think there need to be a little long-term studies on this. I know one of the centers which is following it quite profusely, and they are saying that they are having promising results. But so far, at least, it's not advised. Sclerosing therapy.
Okay. Thank you.
Ashish and then Abhishek, and then we go to the next case, Dr. Sanket Pisat. We have got many questions lined up. So
Yes,
Ashish, be brief, and Abhishek after that, Sanket.
Okay, Amaya, basically, when they are talking about the sclerotherapy, they are doing it from the transvaginal route.
Yeah.
So always, whichever procedure is going to be done with the transvaginal route, there is always a chance of infection.
Infection.
Yes. And again, what Rohan was talking about, the rate of recurrence. There are no published yet data to know whether the recurrence is how much is the recurrence and in what capacity.
Ovarian abscess is known after that.
Yes.
Thank you. Before I go to yes, Abhishek, sorry.
So the sclerosing therapy, and you mentioned Horace Romans. I was with him for a week or so before the lockdown, and I landed in Mumbai just the time when the lockdown kicked in on March 13. So they do sclerosing therapy, but they do it laparoscopically, and this is only indicated for cysts larger than 6 centimeters. So they don't want to damage the ovarian reserve with a cystectomy. So they do that, and they will wait for 3 months, and after that they will do a second step surgery where the cysts have reduced in size to finish the deep endo. So it's a 2-step procedure.
Okay.
And they have
it's a laparoscopic approach.
Yeah, laparoscopic, not vaginal. Vaginal is very dangerous.
They used alcohol, is it no?
Yeah. Pure ethyl alcohol, 95%.
95%.
Right. Sanket.
Thank you. Yes, I got
Sanket,
many.
want to add something?
No. No. I want to add some comments here by the viewers. Please keep one more webinar. Very interesting discussion. This is Dr. Hema Menon. Thanks for the webinar. The discussions are excellent. Thanks. This is Dr. Marina Shaila from Shillong. This is Dr. Rohini Limay from Kolhapur. Nice selection of topics. Very useful to all age group people. I mean, obstetric gynec consultant and students even. So that's what we started, endoscopy for all. and endoscopy for every gynecologist with a vision from AMOG's president of AMOG's Dr. Nandita Palchetkar and the president-elect of FOXY Dr. Rishikesh Pai, and guiding force behind this Dr. Prakash Patil of MAGE. So that's what we have got this together. We will understand and we will get back to you for a second round. Thank you so much. Now I call upon Dr. Sanket Pisat. Dr. Sanket Pisat is a very kind-hearted and very sober and very gentleman of a man of few words and always polite. And he is the darling of Mumbai Obstetric Gynaec Society, I can say. He is he is a member of the managing committee of MOGS, a gynec endoscopic surgeon. I think he's probably the second or third generation gynecologist. You may correct me on this. He has done his MS and DNB. He was a student with me. Then later on, he went to JJ School, medical school at Grand Medical College. I had spent about 1 month with him before he landed up at JJ. The reasons he know why. And then he has blossomed into, after his post graduation, he has gone to Belgium. He has learned with von Herendal and also to Italy. He is also a faculty at Ethicon, EISE Mumbai, and attached to many hospitals. His own hospital is Akansha Hospital at Andheri, Nanavati Super Speciality Hospital, Holy Spirit, Apollo Hospital, Raheja, BSCS Global Hospital, and the most important thing, he has got many awards, including the Dr. Pramila Bhatia Scientist Award, and the most important landmark achievements as an endoscopist or as a gynecologist, you being a scientist, when something gets patented on your own name and you start devising things. And that's a very important landmark when you in your career do. And I think that is going to be a very important thing what he has done for laparoscopic myomectomy. And I want to say here he has devised Pisat's visual vasopressor injection needle. It's an internationally patented. I think the tip after the needle, it has got a transparent glass, so you can see through whether actually you have gone inside a vessel when you are putting in petricine diluted, because that was not possible when you had a metallic syringe and a needle. So this was a very big breakthrough, and I think that was a very important thing. And second is he has devised a shoelace knot, a method for reversible ligation of uterine artery at its origin in patients undergoing myomectomy desirous of future fertility. And I want to tell you that this has got published in the official journal of AAGL. So with this, Dr. Sanket, it is a pleasure to have you. I would like you to read your case and then we will go with the discussion.
Thank you, sir. It is an honor to be invited by you on this meeting with so many important faculties which are there, and I hope I can do justice to my presence here. So this girl is a 29-year-old married woman. She complains of severe dysmenorrhea and dyspareunia. She underwent a laparotomy before, and the surgery was abandoned due to frozen pelvis. So what is the further management? Now, clearly, because she has severe dysmenorrhea and dyspareunia, the question of managing her conservatively is out of the question. She is definitely going to require surgery, but let us consider that a competent gynecologist has abandoned a prior surgery. So when we are going to go in for a surgery the next time, there are several things that we need to understand. First of all, before posting this patient for surgery, apart from the other preoperative investigations, personally, I would like to do an MRI. I know that there are people, Abhishek is one of them, who is doing excellent imaging on his own, who is quite good at his own ultrasounds. But personally, I do not do my own ultrasounds that much. But I would like to do a preoperative MRI just to find out exactly what is where. How much is the uterus? Where are the ovaries located? What is the extent of rectal adhesions? Is there serosal infiltration or not? Whether the uterus is adhered to the anterior abdominal wall. So quite a few things can be found out on the MRI itself. Based on this information, I will be able to counsel the patient preoperatively, realistically, about what is the risk of surgery, how much is the risk of colostomy that we can expect after the surgery, is there a risk that I may start and close the abdomen again? Because though the surgical skill may be there, there is always a possibility of finding something unexpected inside. And based on all this, then we would post the patient for surgery. The primary problem in this patient would be entry of the first trocar. After that is done, the rest of the things are dependent upon what you find inside. But for this particular patient, personally, I would choose open laparoscopy and entry in a high supraumbilical or a supraumbilical entry by open laparoscopy as the entry of choice. And the other options, of course, are doing a Palmer point entry or insufflating via the Jane point. But personally, I would prefer open laparoscopy technique. Once this is done, there will obviously be a lot of bowel adhesions. These will have to be dissected away using a cold scissors rather than an energy source. And then, as the surgery proceeds, the dissection will have to be done visualizing each structure by and by. In fact, the so sure technique, which is demonstrated by quite a few people, including Dr. Ameya Padmawar, Dr. Sandesh Kade, has to be religiously followed. And one by one, every organ has to be separated until everything is put in place. The last comment that I would like to make for this particular case is that for this case, I would like a proper OT setup, good anesthesia, and an efficient surgical team. So I would like my assistant to be as competent as me. So I would like a person who is good at endoscopic surgery to be assisting me. If not, then at least someone who has trained with me for a long time, so he or she knows what I want. And secondly, I would like to have a multidisciplinary approach for this particular patient, meaning that I would like to keep a surgeon and a urologist available at least on standby in case I do need it. Though I may be able to suture the bladder, I may be able to suture the bowel. In this day and age of medico legal concepts, and considering that I practice in a city like Mumbai where there is no dearth of super specialists, the fact that a super specialist was not kept handy for such a difficult case is just not acceptable to the court of law. So I would like to do this surgery as a multi-speciality approach with a good camera system and a good OT setup. That's all, sir.
I think wonderfully you have explained. This patient is actually what I can imagine, unfortunately, is a case of recurrent endometriosis. Abhishek, would you like to agree with me?
So I would go over the previous surgeon's notes quite meticulously. Then, like Dr. Sanket mentioned, you would definitely need an MRI. It's very useful to preoperatively plan your strategy. And there's no question of a repeat laparotomy. I mean, in the old textbooks, it was written that a frozen pelvis is a contraindication for a laparoscopy. In this day and age, I would argue that it's the exact contrary to it. If you are doing a laparotomy and you find a pelvis, close it and then put a scope in, then you'll be able to actually solve the case if you're competent enough. But there's no harm in if you accidentally diagnose it and say, okay, I'm not going to proceed, and then document your findings and then refer to a specialist center with a multidisciplinary team. As he so very well articulated that. So that's pretty much all to add in this situation.
Amay, your take on this? As an endoscopic surgeon?
I would agree with the approach, and of course laparoscopy with the high-end magnification which you get, we are able to identify and dissect the tissues better, conserving the necessary organs. And it will, the retroperitoneal approach is going to be the solution for tackling this case.
Thank you so much. Thank you. Now, I want to tell you, today we have 1,252 viewers to be precise who have logged in today. We started with anatomy. We went ahead with the whole physiology. We also went through simple cases to begin with in a young girl, from there onwards to a married woman, to an infertile patient, to IVF consultants, to recurrent endometriosis, further rectovaginal plate endometriosis. So it's been an amazing journey, and there are so many messages that have come to me. I have gone crazy reading them, and I would request to take few questions by you. as we are also crossed more than 2.5 hours. So there are few questions which you would like to take, and I would like to start with this. Just give me one moment. This is Dr. Poonam Gupta from Varanasi. How to manage patient with previous 2 surgery for chocolate cyst, 20-year unmarried female, and again with severe pain in abdomen. I think Dr. Nitin Shah, is he there with us? I would appreciate him to come on board. Dr. Nitin Shah. In case he is not there, I request one of you to take this question. She has undergone 2 previous surgeries. Yes, one of you can answer this question. Yes, Sanket.
Yes, sir. So Nitin is here.
Nitin has come. Nitin has already come. I probably
just repeat the question. There was some problem
he
with
just went
internet.
and did one surgery and he has come back. And I want to introduce him, Dr. Nitin Shah. Dr. Nitin Shah is a great surgeon. He is a part of our AFG team. He is presently the joint secretary of AFG. He has done his MS Gynae, DNB, FCPS, DGO, and diploma in gynecology from Germany, IVF training from Israel. He has been practicing for last 15 years, 25,000 laparoscopies, national and international publication, 10 cover pages of Jogi, trained many gynecologists. He's a hardcore endoscopist, and I admire his energy. You can say he's Amitabh Bachchan of endoscopic, the younger generation, because his voice resonates nothing less than Amitabh Bachchan.
Thank you.
And recipient of Golden Hand Awards, recipient of Wonder Foxian Award, world record holder for removing heaviest TR fibroid, largest para-ovarian cyst, and hysterectomy in male. Amazing. Nitin, I could not introduce you in the beginning because we had some technical issues of showing your CVs. So I think I've given you this justice and I've completed everyone's CVs. And it is very important to introduce a person. It is very important to introduce the person who has taken so much pains to come up to this level. So, Dr. Nitin, thank you for being there with us. Saying we started with the first case at 7:30, and you are still hooked up because there are many questions which are there, and
we'll
answers. So now I request you to please continue with your answer.
Sir, can you repeat the question? There was some problem with internet. I could not listen to the question.
Yeah, I have to go 1 hour behind. Just wait, please.
If somebody else can answer if they have understood the question.
How to manage? This is Dr. Poonam Gupta, Varanasi. How to manage patient with previous 2 surgeries for chocolate cyst, and she is a 20-year unmarried female, and she has come with severe pain in the abdomen. See the fate in Varanasi. We have this lady, a young girl, unmarried, undergone 2 previous surgeries.
First of all, we should try to postpone surgery as far as possible in unmarried girl and young girl of endometriosis. Previous 2 surgery was also, I think, might be done for some severe indication. But as far as possible, we'll try to avoid the surgery in young girls. Try to manage with medical line of treatment, either in the form of Dynogest or continuous OC pill. What we use, extended OC pill regimen. One can go ahead and use that. If possible, can use Lupride depot to down-regulate for a couple of months and then, take over with the Dynogest. But if she has already undergone 2 surgeries, this time we will evaluate whether the surgery is needed. Because doing such a frequent surgery will also reduce the AMH and ovarian reserve for the future fertility point of view and will just add on to the fibrosis and the adhesion. So we try to postpone surgery this time and not to be in very heavy.
Absolutely agree. But now she has undergone already 2 surgeries.
If required, then best person on the earth should do this surgery.
Sorry?
Yes.
Come again?
Come again,
please.
The 2 surgeries already done, then we should avoid.
Okay. So then,
if at all, will have to.
Rohan, Amay, Nitin doesn't want to touch her.
So I agree with Nitin sir that we should not be touching her. Firstly, we should be finding out the notes from before about what surgery she's undergone, what is the procedure being done in those this. And I completely agree with Nitin sir that the medical management should be medical management treatment should be done for her in term of either Dynogest or extended OC pills. I think now there are OC pills which have come with Dynogest in it as well. I personally don't have any experience with it, but you can consider using that as well. Again, I reiterate my point about offering oocyte cryopreservation for such a young patient who's already undergone 2 surgeries before. We should offer the option to her. Whether she takes it or not is up to them, but it's important to give them the availability that there is such a treatment available and explain to them that oocyte quality and the reserve is going to reduce if she undergoes a recurrent surgeries as well.
Nitin, I like your matching t-shirt with your matching background of your cupboards. Is it by purpose?
No, sir, I am sitting.
Next time we'll have a very fantastic background now. Niranjan.
Abhishek, I want your take on this and then we will go to the next question.
Yeah, I wanted to refrain from commenting on very short things because 1, you don't know what her symptoms are. 2, you don't know what the previous surgery is for. 3 is just saying 1 4-centimeter endometrioma. That's not really a diagnosis. I would like to sit down with the patient and understand her history and what her complaints are before even venturing a decision in that management.
Okay. I think that's done. There is Dr. Nice discussion, great panel. Dr. Alka Kute from Amravati. Dr. Sureka Yadav, amazing discussion. I think she's from North India. Dr. Anupama Patil, great webinar, sir. 1 minute. I have to go back. I'm traveling in time behind. This is Dr. R. Sasikala from Puducherry. Likelihood of torsion in chocolate cyst. Anyone can take this.
Unlikely.
No, never seen torsion in an endometrioma because of the adhesion, and it's not a true encysted cyst. It's an invagination of the cortex. So rarely you will not get torsion. If it is torsion, it is hemorrhagic cyst and not an endometrioma.
Exactly.
Endometriosis.
I've had one case that's just come to me. She had a torsion.
Okay. I think it's amazing the discussion. I want one-liners from each one of you regarding elusive endometriosis, and then we will close this webinar. I start with the first Dr. Rohan, then we go ahead with the next as we go through the cases.
So again, I will reiterate my point. Offer oocyte cryopreservation, especially to the younger patients who do come with endometriosis. And it's not just the younger patient. All your patients that come, give them that option, especially if they are considering fertility or considering to postpone fertility for any reason.
Okay, Ashish.
Pertaining to the one-liner is like that. You have to think about the age of the patient, which age group she belongs to. If she is a reproductive age group, what is a potential factors that is going to deteriorate, and thinking of early pregnancy in the reproductive age group.
Yes. Next, Abhishek.
Yeah. So I mean, a lot of people have said that everybody should be doing endometriosis surgery, but I will say that advanced disease should be handled at multidisciplinary centers with a great experience of endometriosis, because this woman should have one final surgery and that be the end of it all. She can't go through revolving door surgeries every year. So just like I always tell, you cannot go to a general surgeon to get a brain tumor operated, but this is the most difficult surgery in gynecology. It's more difficult than gyne-onco. So why should it be in the realm of, there should be privileging for surgeons to be able to perform special surgeries.
Yes. Now I go to Dr. Nitin Shah.
Yes, my take-home message will be delay the first surgery. Delay the first surgery, preserve the fertility, and should be operated by expert only.
So you do not do an incomplete surgery. The idea is that if you go in, you do a complete surgery,
Complete surgery.
try to
And
remove
delay the
all the
first surgery as and when
endometriomas.
required.
Sorry, I'm sorry.
Delay the surgery in young, delay the first surgery.
Yeah, in young, and then if it is married, and then you have to go ahead do an endoscopic surgery, but do a complete surgery. Don't keep anything remaining back because they come back. Amaya,
Yeah.
Dr. Amaya.
When it comes to surgery for endometriosis, know your retroperitoneal anatomy really well.
Yes,
Yes, right.
very nice. Yes, Dr. Sanket.
I think it would be the one line take home message would be tailor the surgery according to the patient's needs. It doesn't matter how much I can do, it matters what the patient requires. So, do what is required for that particular patient, particularly in fertility enhancing surgeries. It's not so much important how much you remove, but what you leave behind that is functional.
Thank you. Dr. Prakash Patil.
Yes, Niranjan, it is a really amazing discussion. I just wanted to highlight 3 or 4 points. Number one, whatever everybody said, that the patient counseling is very important in this. Patient should be told that this is a progressive disease. You just cannot sit on the disease. That is number one. Number two, the unmarried girls, they should be treated conservatively with medical line of treatment unless they are very much symptomatic. Number three, while doing this surgery, we are supposed to keep distance from the ovary to see the ovarian reserve, because ovarian reserve is very important even in future. And the last thing is that the patient should be told if the AMH is low, if the age is more than 30, they should be told, rather than doing all other treatments, it should be advised IVF so that they will not be frustrated. So these are the few points I want to highlight. That's all.
Yes, thank you. Thank you so much. I'm still getting comments and just wonderful. We have got more than 1,252 users who have logged in, and it has gone absolutely great. I think we have to understand the sentiments of our users, and I will be calling you back again. So please,
Certainly.
by the
Certainly.
end of September, I think we will have a different scenario of cases, and then we will be having the same panelist. If you are there, well and good. And that's what happens when you're working for an organization. It starts at grassroots level. I remember when I became the managing committee member of MOGS in 1997. But before that, I toiled for 5 years making those master of ceremony presentations, and putting the tablecloth on the podium, even getting the CVs. And that's how Rohan and all of those members in Sanket, and you can recollect yourself, Prakash Patil sir, that it starts from the grassroots level. And that's what we have now come back, and it's 50 plus years of my age. And when hair becomes gray, and that's what experience increases, you want to contribute more to the society back. And that's exactly what I'm doing. I'm just coming on the scene, just a mediator being here. I want to educate more. I want to do more in endoscopy, and that's the reason I have called you all. That's for my candidature of an IAG treasurer's post. And if you consider me to feel worthy, I would request you to vote for me. That's what I appeal to all of you. And thank you so much for joining us. It was a wonderful Sunday evening.
Last two
Usually,
sentences. I want to conclude with 2 sentences after you.
yes, sir. Please, sir.
It was really amazing discussion, and thank to all the panelists on behalf of MAG as a chairman of MAG. Thank to all the panelists, particularly Dr. Niranjan for conducting this webinar excellent way. Dr. Ashish, Dr. Amaya Padmar, Sanket, Rohan, Dr. Ashish, everybody contributed very nicely. And I wish Dr. Niranjan a great success in his election, certainly. We hope that everybody will vote for him. He is our colleague and he is a deserving candidate. That's what I think. I'll request all of you on my behalf to vote for him. And thank you very much once again for sparing time and your skill. Thank you.
Thank you so much.
Thank you, Niranjan.
Thank you, all of you. We will get back soon. Yes, Amay.
Thank you
Yes,
very much.
Sanket, Ashish, Abhishek Mangeshikar.
Abhishek, yes, Abhishek also.
Thank you,
And
sir. And sir,
Rohan.
best of luck for your election, sir.
Thank you.
Thank you.
Thank you so much.